Software being auctioned, starting with the base price of 10,000 rupees. Those who are interested can try to bid for it and get it. So there is a quiz competition, there is an auction. An important announcement is that do not move around. Those who are near the doors, don't open that. There is only one entry on the right side. No back doors and side doors to be used. Enter or leave only through the doors on the right side. Thank you.
Good morning, everyone, and a very warm welcome to all the delegates of EXPLORA 2025. We are delighted to present a very special event, the live auction of the Zoomeo Elite software, one of the most advanced homeopathic digital tools available. To make the process simple and seamless for everyone, we request you to scan the QR code that will display on the screen. This will take you to a dedicated WhatsApp group created exclusively for this live auction. Scan the QR code, join the WhatsApp auction group, stay ready to place your bids once the auction begins. As soon as we announce the start, you can quote your price, participate actively, and bid your way toward owning this powerful HomePit software. So get your phones ready, scan the code, and let the excitement begin. Wishing you all an enthusiastic and joyful bidding experience. Dear delegates, kindly note the QR code to access all the conference photos is available at the MC desk, the registration counter, and near the dining hall. Please scan it at your convenience. Good morning, everyone, and a very warm welcome to Day 2 of EXPLORA 2025, the International Homoeopathic Conference organized by Muller Homoeopathic Medical College in collaboration with the Global Homoeopathy Foundation and in association with the Central Council of Research in Homeopathy. As we gather here from different corners of the world, we bring with us diverse perspectives and one shared purpose: to learn, to collaborate, and to envision a stronger future for homeopathy. A warm welcome to each one of you. The Open Forum is a platform for vibrant discussion, exchange of ideas, and collaborative learning. Today, clinicians, academicians, and researchers come together to share experiences, raise questions, and explore innovative approaches in homeopathy. We now proceed to the open forum. Joining us here are three accomplished speakers who will share their expertise and enrich our understanding of homeopathic practice and research. We are delighted to welcome the moderator for this session, Dr. Praveen Rajpi, a distinguished academician and researcher in homeopathy. A graduate and postgraduate of Muller Homoeopathic Medical College and a PhD scholar from Tantia University. He has served as principal and now serves as professor and advisor at Alva's Homoeopathic Medical College. An accomplished author and columnist, Dr. Praveen Raj has published numerous books and research papers and is a respected examiner for several universities. His vast experience and insight make him exceptionally well suited to guide today's discussions. It is an honor to have him as the moderator for this session, and we warmly welcome you, sir. We now commence the session, marking the beginning of an engaging and insightful discussion. Let us begin the session by welcoming our first speaker, Dr. Anis Fatima B. Talur. May I request the upcoming speakers to kindly be seated in the front rows as we proceed with the session. Delegates who are interested to participate in OSCE workshop in Organon and Materia Medica and focus small group discussion with Dr. Ashley Ross and Dr. Kim Jobst are requested to contact help desk near the registration counter.
Yeah. Do you have a mic? Good morning, Mangalore. Respected dignitaries, my colleagues, and dear students. It's a great privilege to present our case study at this big platform. I give big thanks to the organizing committee to give an opportunity to come here and present our paper. So this is my own case study of where we need to intervene in post-surgical complications. So as we know, as per homeopathy, we have got some limitations also. In some cases where we need to go for surgery, we need to advise the patient for surgery, but some complications which arise in post-surgical period, we can prove our remedies as giving the best results. Now this is my case, which I have seen the patient very closely. This person went into very bad post-surgical complication after the open surgery to remove 25 mm stagnant stone from the kidney, and he was suffering from kidney stones for last 20 years. So all the time it was to be very small stones, and he took all medicines he said he's taken homeopathy also, Ayurvedic also. But at one time when the stone was so big and he had to go for surgical removal, and then he went into a very bad complication, had pyrexia, fever, high fever for 21 days. And then after lot of trial, after the antibiotics, higher antibiotics, they consulted me, and with homeopathy, the results were amazing. So this is a post-surgical fever in case of renal calculi with hydronephrosis. He had 25 stone and a gross hydronephrosis of right kidney. Can be a sign of either a common physiological inflammatory response to surgery or more serious complications like a urinary tract infection. Causes of fever may include the body's natural response to tissue damage, the manipulations of stone during procedures like PCNL, open surgery in big stones, and residual urine and bacteria in the urinary tract due to the obstruction from hydronephrosis. Factors like diabetes, large or staghorn stones, history of UTI, and the complexity of the surgery itself can increase the risk of fever in post-surgical period. Common causes for fever, again, are inflammatory response, bacterial contaminations, residual urine. Pre-existing factors like diabetes mellitus, preoperative UTI are significant risk factors for developing post-operative fever. Stone characteristics, large or staghorn stones are associated with the high risk of fever, possibly due to their tendency to obstruct the urinary tract and promote bacterial growth. Surgical factors, the number of access points used during surgery, the complexity and length of operation. Now this patient has undergone surgery and that length of duration of surgery was almost 3 hours. Significant blood loss during the procedure. Patient aged 46 years came with complaints of post-surgical fever for last 3 weeks. Fever was high grade with malaise, chills, and followed by profuse perspiration. The patient developed post-surgical complications and initially he developed with lower abdominal pain, tenderness, malaise, chills, and fever. Investigations were again repeated with respect to urine culture, sensitivity, blood culture, blood sensitivity, because they wanted to repeat the antibiotics, and depending on the culture sensitive report, they were giving the patient the higher and the higher antibiotics. One time the patient told me that they had prescribed him an antibiotic. It was in the sachet form, and the cost of this medicine of single dose of antibiotic was costing him 5,000 rupees, and it was not easily available to the patient also. But with respect to, can say, the getting treated or getting well, they have even tried all the ways with higher antibiotics, which was not giving result also, and was making the patient more weaker and weaker day by day. There was no result, and the fever used to rise almost at 1 p.m. in the afternoon, and used to reach to 103 degrees. The patient used to go into the fetus position. That means the patient used to wrap himself, make himself very small because there was a lot of chills, and cover himself with 2 blankets and go to sleep. During fever, the attendants at home say that the patient even did not like to be talked to, or never uttered any word during fever. He used to only wrap himself, and he used to sleep for 3 to 4 hours with 1 dose of paracetamol 650 mg, and it used to take almost 3 to 4 hours almost to reduce the fever. This was every day's routine was going on. Afternoon, he used to get the fever, he used to wrap himself, take 650 paracetamol, again reduce the fever by evening, again next day is the same story. When we took the history, when they came to me through the history of renal calculi, largest measuring about 25 mm, and multiple small calculi with severe gross hydronephrosis of the right kidney. He underwent surgery on 21st January 2021. Initially, PCNL was tried, but because of the large size of the stone, PCNL was not successful, and they had to open, and they did open surgery. That I said you was almost for 3 hours. There was a lot of blood loss also during surgery, and because of that, they had given him 1 pint of blood transfusion on the 2nd day. Patient got discharged on 5th day of surgery, and after coming back home, he started fever from 2nd or 3rd day. And because of this complication, this fever, the catheter was almost changed. Initially, they said it seemed that by the time of discharge, catheter will be removed for him. But because of this condition, catheter was changed 3 to 4 times every 5th day. And because of catheterization also continuously, maybe there was infection, but The condition was that unless the patient's fever is reduced and he comes back to normalcy, the catheterization was supposed to be done because the patient was having so much tenderness and abdominal pain after that big surgery that he was unable to easily get up and go to the washroom also, frequently. There is a history of calculi for last 20 years. And he was on treatment, Ayurvedic and all those things. But absolutely, he says that last 4 to 5 years, there was no pain, no discomfort, and he thought that the stones might have passed, the small stones. But in Jan 2021, when he started getting some heaviness into the right renal angle, and he kind of dysuria, he took the scan, and it was revealed that there's one big staghorn stone of 25 mm. This is the scan report of the patient. Now, this is the thing, because this patient, I know the patient very closely, so I was knowing all the history of surgery and the post-surgical fever. So I had said to maintain one record of the fever, how the fever rises and what degree it goes to. So they have kept a record of the fever which started rising from the third, fourth day of surgery. So this diary picture I have taken, what they have kept. This is the testimony of the patient. Can this be played? Yeah. I gave a homeopathic remedy. So after that, from second, third day,
स्टोन था और ग्रॉस हाइड्रोनेफ्रोसिस था और इसके लिए मेरे को सर्जरी जाना पड़ा। सर्जरी होने के बाद 1-2 दिन ठीक था, उसके बाद मेरे को चिल्स, फीवर, बॉडी एक ऐसा होने लगा। मेरा सर्जन ने 2-3 टाइप का एंटीबायोटिक दिया, रिलीफ नहीं मिला। फिर हर 5 डेज के बाद एंटीबायोटिक चेंज दे गया, 15 दिन तक चला रहा है ये सब, तो मेरे को रिलीफ नहीं मिला। ब्लड टेस्ट किया और यूरिन कल्चर किया, ब्लड कल्चर किया, उसमें कुछ सब नॉर्मल ला रहा था। फिर मैं परेशान हो गया, मेरे को बॉडी एक होता था, ऐसा भी फीवर आता था, ऐसा रैप करके मैं सो जाता था। बाद में परेशान हो गया मैं, बाद में अनीसा मैडम डॉक्टर को मिल लिया और उनके कंसल्ट किया। बाद में उन्होंने मेरे को मेडिसिन दे दिया। मेडिसिन देने के बाद 3-4 दिन में मेरे को रिलीफ मिल गया। मेरा फीवर भी कम हो गया बॉडी एक कम हो गया मेरा, और हेल्थ भी इम्प्रूवमेंट हो गया। मेरा अच्छा रिलीफ मिल गया मेरे को।
On symptomatology and on the patient's narration of the symptoms and how he used to feel during fever, and the attenders at the home, how they say, how he used to behave during fever. Considering post-surgical, I prescribed him arnica. First day, I gave arnica every 2 hourly. And then from second day onwards, I told to give them thrice a day. There was slight reduction into the fever intensity from the second day onwards. So after arnica, I have given for 3 days. After arnica, almost after third day, there was no any episode of fever noted, and the patient says that the appetite increased. Mentally also the patient felt very fresh, and there was a very fast recovery of him, which he was having too much of weakness and lethargy during all these 3 weeks time in post-surgery. So only 3 days I have given arnica, and after that the patient started showing very fast recovery. Catheter was removed after third day. When I gave arnica, after the third day of the arnica dose, catheter was removed. And when we repeated the urine routine microscopy also, there was no bacterial growth, or there was no pus cells found, and there was no UTI also was there. And in general, the patient said that the patient has improved a lot. So patient has shown marked improvement in his general and mental health, appetite increase, and good sleep. conclusion of this case, I would put forth as this case demonstrates the effectiveness of homeopathic treatment in post-surgical complication, restoring the health to normal and improving the quality of life. It even helps in faster recovery by improving the patient's mental health. The patient's positive response demonstrates the remedy's effectiveness in managing post-surgical trauma, an important issue. Now, this case I've evaluated further. The case is still with me with follow-ups. The case has been evaluated, and I have prescribed lycopodium as constitutional remedy for this patient. And by now, there are still some small calculi in both the kidneys are noted. Every 6 months, I advise the patient to take USG. So with this, I put forth that we can very well treat post-surgical complications with right remedy. Thank you so much.
Thank you, ma'am, for your thoughtful and evidence-based perspective on managing post-surgical complications with homeopathy. Your contribution has truly strengthened today's deliberations. I now invite our next speaker, Dr. Rumana J. Bankapur, to deliver her presentation. Dear delegates, kindly note those who are interested to participate in OSCE workshop and Organon, Materia Medica and focus small group discussion with Dr. Ashley Ross and Dr. Kim Jobs are requested to contact help desk near registration counter.
Yeah, ma'am. Yeah.
The QR code to access all conference photos is available at the MC desk, the registration counter, and near the dining hall. Please scan it at your convenience.
With this, we have to do next one. Good morning, everyone. My today's topic is utility of Kent repertory in the management of essential hypertension, pre-retirement employees and interventional study. Retirement is a significant change, often underestimated the stressful life. Pre-retirement person will more anxious about thinking about his life after the retirement, as to how he will spend his time, not only the time but also the money to meet his requirement, so that he can stand on his own negative reaction to the being retired. By this time, the feeling of unproductiveness, economic hardship and loneliness, this will be started, and so far the person will become the very natural to experience the symptom like stress, anxiety, depression, frustration, diminish of sense of worth, self-esteem and moral, which occurs when one is withdrawing from the job, which can be negatively impact on the mental health. So this impact is there on the pre-retirement employees, where this is one of the cause which leading to the essential hypertension, or you can say the primary hypertension. So hypertension is a leading cause of the high morbidity and the mortality, ranking third in globally. It is a disability adjustment life year, and homeopathy can help in management of the hypertension without prolonging the conventional medication, avoiding the comorbidity and as well as the improving overall health of the patients. Here aims to assess the effectiveness of individualized homeopathic remedy in the treatment of essential hypertension using the Kent repertory in pre-retirement employees. Secondary is to study the hypertension among the pre-retirement employees and determine the domestic social factor associated with it. Here, the 18-month study has been done where 50 patients were screened, and this is the patients were, or you can say subjects were taken from the OPD as well as the IPD and from the AIIMS Homeopathic Medical College. The research design is a prospective single-arm study. Here, single-arm study is being done, and this is an interventional study, and the purposive sampling method is done. That is, purposefully the pre-retirement employees were been selected here. A random sampling procedure is being done. Inclusion criteria: already diagnosed cases of the essential hypertension subject were took, where the systolic blood pressure is ranging from the 140 to 180 mm of Hg, and whereas the diastolic blood pressure is ranging from the 90 to 110 mm of Hg. And the subject aged between the 55 to 60 years of age, that is a pre-retirement age, subjects were been included in the study. Both the genders as well as the all socio-economic groups were considered. Exclusion criteria: the subject with the secondary hypertension, isolated systolic hypertension and malignant hypertension, the subject with the history of the drug abuse and alcohol abuse are being excluded. The proper case taking has been done here. Means like full case taking history was been taken. Selection of the remedy. Here, in this case, the mental as well as the physical general and the blood pressure of the patient is been considered for the selection of the remedy. Individualized remedy has been prescribed. The potency started with the 30, 200 and 1 ml as per the need of the case. The follow-up criteria will be done every 15th day for the 3 months, after once in every month as per the need of the case. So this was my study, like 18-month study was been done, and now among the 50 patients, the 41 patients were shown the improvement, both the mentally, physically, as well as there is a blood pressure has been reduced. So here, the homeopathy offers the holistic approach to manage the essential hypertension without prolonging the conventional medication, avoiding the comorbidity and improving the overall health. This approach helps to prevent the constant medication use of the side effect in the pre-retirement individuals with the essential hypertension. This is the result where the 21 patients were shown improvement, 9 were not improved. Age group wise, we can see the 58 to 60 years of the age where more patients were seen here. Gender wise, if you'll see, the males are more commonly affected in this study. And this is pre-retirement months, means from the 18 months to the pre-retirement was the age group where, or you can say the period where the hypertension is considered more here. And occupational, while if you go, the public sector will be having the more affected here. And the symptoms like the headache, gastric trouble, memory weak, loss of interest, and lack of confidence, worry, giddiness, anxiety, the more of the patient will be presented with the headache and gastric troubles. The remedies prescribed here were arsenicum album, nux vomica and sulfur was the more frequently used remedies, and the calcarea carb, lycasis and the nitromur were prescribed. So conclusion, the role of the individualized homeopathic remedy given after the repertorization with the Kent's repertory in the management of essential hypertension in the pre-retirement employees, which shows the tremendous effect in the helping to maintain the blood pressure. These study itself become the like evidential in the homeopathic field, where the less studies are being done in the like on the pre-retirement employees. So this study I had to. So they take like retire from the job, but never from the mind. Thank you.
Thank you, ma'am. Your presentation offered valuable clinical understanding and depth. We shall now move on to our final speaker, Dr. Vijay Lakshmi Patil. Dear delegates, kindly note the poster presentation competition will begin soon. The participants are requested to report at the help desk. Kindly note the poster presentation competition will begin soon. The participants are required to report at the help desk.
Good morning, everyone. Today I am here to present a very interesting case, a very short case on somnambulism. It's a sleep disorder where it's commonly known as sleepwalking. And here a person gets up from the sleep and performs complex motor activities, remaining in complete consciousness person, and they doesn't remember these episodes when they get up. The point why I selected this case in front of you is usually from the place where I belong to, like Bagalkot. I practice people do not consider such mental disorders or neurological disorders as disease. Instead of seeking treatment, they go to some of the astrologers, babas, etc., thinking that there is some evil power, negative energy, or some karni or some magic is there and all. So the patient is from very poor background and illiterate family, and the ambitious patient, when I interrogated, she said that she wants to become doctor. And one more interesting fact is that I met this patient in a bus, and while interrogation, she became so close to me and she started explaining her complaints to me. And among one, she said that I get up in the night and I woke up, I walk, like everyone complains, as she doesn't remember this, but her parents complains every morning to her. And while interrogating, I could understand that she's more ambitious, and also she has a lack of confidence, fear of failure, etc. And I convinced her parents to visit OPD and take a treatment for such kind of disorders. Okay, then this is the case in front of you. So as I explained, somnambulism is a disorder of arousal typically seen in children aged 5 to 12 years and often resolves spontaneously. However, in persistent or disturbing cases, it warrants medical attention. Homeopathy, with its individualistic and holistic approach, aims to address the root cause of such conditions by stimulating the body's natural healing mechanism. This case illustrates the beneficial effect of Silesia, a deep-acting constitutional remedy well known for its action on nervous, emotional, and physical weakness. So there is a case detail. Patient aged 15 years, female, student. She visited our OPD in a college OPD on 22/1/25. Her chief complaints were sleepwalking. She has episodes for the past 1.5 years, occurring 2 to 3 times per week, and with the headache for 2 days she had. History of her present illness, where the patient presented with multiple complaints of varying duration. She has been experiencing right-sided deafness for the past 1 year, which has gradually developed without any associated pain or discharge from the ear. In addition, she reported a dry, irritating cough persisting for the last 8 days, more pronounced at night and disturbing her sleep. She also complained of a frontal headache for the past 2 days, described as dull and pressing in nature, without associated nausea or photophobia. A notable and persistent issue reported by the patient's mother is recurrent episodes of sleepwalking, that we call it as a somnambulism, for the past 1.5 years, typically occurring 2 to 3 times per week. These episodes involve the child rising from the bed during the night, walking aimlessly around the house, sometimes murmuring and returning to bed without a recollection of the events that following morning. Associated symptoms were nausea and vomiting. Past history, her menses were irregular with clots, etc. And mentals are desired to company, worried about mother, anger, throws the things all the time, and in sleep try to kill people. She holds the neck of people as her parents complain. Physical generals, she is chilly and craves egg and sweets, aversion to milk, perspiration, offensive and staining, disturbed sleep, thirst is reduced, desires for sweet and tea. So here the clinical diagnosis is somnambulism, homeopathic diagnosis, constitutional disorder with symptoms pointing towards cilicia. The repertorial analysis or totality is what I took. Company desires for anxiety, anger, somnambulism, food and drinks, sweet desire. Food and drinks desires are tea and sweet, and milk aversion, and she has cold aggravation and sleep disturbance. So the remedy I got in the first grade was cilicia, calicaria, and natremure in the third place. And remedy I selected based on the totality of symptoms, especially the chilly disposition, profuse head sweating during sleep, timidity, lack of confidence, obstinacy, and recurrent somnambulism. So cilicia 200, 1 dose I prescribed with a placebo. And her follow-ups are like after 15 days when we called her, only 2 episodes of night walking reduced. Once in a week she had a sleepwalking and murmuring, etc. And the sleep was improved, and headache was continuous, and earache with cold and coryza was there. And next follow-up, night walking completely reduced, and headache was reduced, earache was it was there, cold and coryza, and we observed the Hering's law of cure, like how from inner to outer. She had a itching urticarias on her all over body, and with placebo we sent her, and she came on 4/3/25. There were no episodes at all during those weeks, this week, and headache completely reduced, and itching also was reduced 80%. And again we prescribed placebo, and she got cured of 80% of her complaints. Outcome and follow at the end of 3 months, the patient remained free of somnambulism. Her overall confidence was improved. She interacted better with the classmates, and physical generals showed marked improvement. A 3-month follow-up confirmed the continued absence of symptoms. So the discussion goes, this cause highlights the role of individualized homeopathic treatment in functional disorders like somnambulism. Cilicia, known for its deep constitutional action, addressed both the somatic and psychological components of the case. Conventional treatment options are limited to behavior modification and sometimes sedatives, which offer some symptomatic relief. In contrast, homeopathy can provide a long-term solution by addressing underlying susceptibilities. Conclusion, the selection of cilicia in this case is based on the totality of symptom, mental and physical generals, and miasmatic background, aligning with the principle laid by Dr. Samuel Hahnemann in the Organon of Medicine. With this, the moral remedy like family counseling, patient counseling was also done. The patient displayed classical features of cilicia like timidity, lack of confidence, etc., and great sensitiveness, reading disposition, lack of self-confidence. So these are the references. Thank you. Thank you, Father Muller, Homeopathic Medical College, and EXPLORA, Global Foundation, and CCRH for giving me this opportunity. I especially thank Dr. Kiran sir for giving me opportunity to speak in front of you. Thank you, everyone.
Thank you, ma'am, for your valuable insights. We now invite our moderator, Dr. Praveen Raj, to share his insights and reflections on the session.
In the meanwhile, there will be a quiz which will be going live now. So I request those who are here to download PAN Quiz, PAN, PAN Quiz. It's an app from Play Store. You can download that. Thank you.
Very good morning, everyone. Just now we had these three presentations, and we know we as homeopaths now face various challenges in our clinical practice. And what we noticed is all these three have taken three different areas, and all these three areas are one which we have challenges when it comes to, I call it Western medicine. Now, it also highlighted to you one more thing, that a systematic approach in these areas, you find that a desired result definitely comes. In the first case, Dr. Anis, who presented with the post-surgical fever case, you find that case was purely a surgical at that point of time. But you see the fever case after surgery, which with the homeopathic treatment found to be with ease could be managed, you found that Western medicine did find a roadblock. It looked easy, but at the same time you find that the conventional medicine does have a lot of limitation in that area, but we could manage it within a matter of 3 or 4 days with simple medicines like arnica and followed up by the lycopodium. Now, the second case, when you see Dr. Romana was presenting with hypertension in a good number of 50 cases, systematically worked out cases. Now, this type of study we find quite often. I think many of the postgraduates also keep doing this one. I think we need to go to the next level of doing a research on, especially on hypertension. Area is very good. It is a pre-retirement age, a change in life. Now, what can be done further on this is, one is, you can develop your own tool on this, that certain remedies do come, as she noticed. Certain remedies definitely will come, and that would help us in managing it is one. Second, see, it is not that our treatment is very, very specific for hypertension. Rather, it is a treatment which is based on a broad-based treatment, as homeopathy always suggests for. Now, this broad-based treatment would help, especially conditions like hypertension or diabetes or whatever you talk about. Morbidities, following morbidity is also very important. A prolonged study, something like a case control studies, or a prolonged, certain studies today happen which is for long years, 5 years, 10 years, if you're able to do with enough resources in hand. That can give us whether these hypertension cases which we treat, they stop with only that. They don't allow to go for a further morbidity, which is presently a very big problem with most of these diabetes or hypertension, where they don't stop with that. They go with the other end organ complications. We can definitely stop that. That is where we have to go about, is one area. Second, it is not just hypertension, it's also a matter of this person who develops hypertension over a period of time. You see that they may become diabetic, or they may become hyperlipidemic, or something else they develop along with that. Our treatment, as it is a broad-based, we are able to control, prevent, and make that person. Sometimes we find they're coming back to in their age. Maybe a 50-year-old will become, energy level can come into a 40 years level. So these are the areas where I think our next level of our researchers has to go into a different ideas, rather just controlling only one particular disease aspect, and that is the biggest concern and botheration of today's society. Dr. Vijayalakshmi presented with the somnambulism case. Seems to be a simple, again a roadblock for Western medicine, but it is these are the cases. Again, you see the Silesia. Everybody knows Silesia is one of the very good medicines. So again, the patterns what you see is most of the polycrests do come in most of our cases, whichever may be the diagnosis you come up with. But more go into you tomorrow, as many of our young homeopaths are seen here, many of your students, postgraduates, researchers. You need to go more into maybe certain diseases or certain aspect of a single disease where become expert in that, and you will understand the growing vistas of homeopathy in these areas where you definitely will come up with very high success rate of managing them. Not only that, let it not be remaining within, that's the concern, not only let it remain within the faculty of fraternity of homeopathy. What is happening today is it mostly remains within us, and our public at large remains in the dark. We discuss among us, we talk about this, we pat our back, but our public grope in darkness, they go for conventional medicine, struggle like anything, and at the end, whatever the benefit they are supposed to get, they don't get, and whatever the merits we as homeopaths and the system as homeopathy is supposed to get is not getting. With that thought in putting across you, thank you, and I am signing off.
Thank you, sir, for your valuable insights and for steering this open forum with such clarity and purpose. We now come to the close of this open forum. I take this opportunity to thank all our speakers for their valuable contributions and our moderator, Dr. Praveen Raj, for leading the session. May I now request Dr. Praveen Raj to kindly present certificates to the speakers as a token of appreciation. Dr. Anis Fatima B. Talur, Dr. Rumana J. Bankapur, Dr. Vijay Lakshmi Patil, Thank you, sir. Now, may I invite Dr. Kurian PJ, Professor and HOD, Department of Repertory, Enapoya Homeopathic Medical College, to present the token of gratitude to our moderator of this session for his valuable contribution to this session. Thank you, sir. We are excited to announce that the quiz competition will now take place. Participants, please get ready, and audience, get set to cheer and enjoy the challenge. I request all the delegates to download the Pan Quiz app from the Play Store. Now, I request Dr. Kannan to take over for the quiz session.
Good morning everybody. So first of all, to participate in the quiz, I'll give you a minute. You will have to download this app, Pan Quiz, or you can go directly to panquiz.com, or you can scan the QR code which will be on the screen now. Sorry, I think the internet is little weak here. Yeah, now it's come. You can download this and join. In all GHF conferences, we have this, and all the questions are from the speakers. So yesterday's speakers, whatever they have spoken, a question is taken from each speaker, and all questions will be based on that. And the prizes are sponsored by HomePath. The first prize will be fully working software worth almost 23,000. The second will be a Firefly Prime, which is also fully functional, and that's also worth around 4,500. The third prize is also a Firefly, so there's ample opportunity for you to grab those prizes. Only thing, you have to listen to the sessions. And there will be another quiz after the second day also. So all of you have an opportunity to grab the prize. Now we have around 300 players already logged in. I'll give you a minute more so that others also log in. HomePath has been associated with GHF for entire series. For all the conferences, this quiz program goes on with GHF. Still anybody to join? Raise your hands. If most of you have done, then no problem. If anybody else is there? I don't see only one, two hands. Okay. Yeah. Some players have logged out. Okay. Okay, I'll start now because we don't have much time. Okay. Dr. Praveen says wait for a minute. Okay. He wants this figure to touch 400, I think. And tell your friends who have missed, because half of the auditorium is empty, so they lose a chance. Some people don't have stable internet connection, I believe, because it was 390 for some time. Now it has come down. Can we start, sir? Yeah, now I'll start.
Pan quiz. In the bench signals to barn-side outcomes framework, which of the following best represents a Tier 3 translational field outcome for a veterinary homeopathic intervention? A. Demonstrating reduction of bacterial growth in vitro using broth dilution assays. B. Showing modulation of cytokine expression in a mouse mastitis model. C. Documenting, in a controlled farm trial, reduced clinical
Okay. Now you have just 20 seconds for this. Very few people have answered. Be ready for the next question. Okay.
Will AI replace a homeopathic doctor? A. Yes, AI will completely replace homeopathic doctors. B. No, AI will assist homeopathic doctors in finding the simillimum more quickly and efficiently. C. Yes, AI will make homeopathic doctors obsolete.
Okay. Somebody was listening then. Okay. See, the automatic reading option will not complete reading. It is only 20 seconds. Okay. So next question.
The family name of the plant Bryonia alba. A. Malvaceae. B. Asteraceae. C. Menispermaceae. D. Cucurbitaceae.
This almost 380 people answered, the highest.
In the context of homeopathic practice, why is healthy self-esteem important for a physician? A. It helps maintain impartiality, empathy, and emotional balance during case-taking. B. It reduces the need for repertorization. C. It makes the physician more competitive with peers. D. It decreases the...
Good. We have totally 4, not 8 people participating now.
In the research done, which homeopathic remedy was most efficacious in the treatment of PCOS and which homeopathic remedy was most efficacious in treatment of PCOS along with yoga? A. Calc.carb and Natram mur. B. Lycopodium and sepia. C. Phosphorus and Natram mur. D. Phosphorus and Calcarea carb.
If you answer fast, you have better chances to score. The time is also taken care.
What is the specific score commonly used for assessment of joint health in persons with hemophilia? A. HJHS. B. DAS-28. C. WOMAC. D. COS.
Yeah, we can celebrate later. Please be on.
Which bowel nosode was prescribed for gut flora restoration? A. Gartner Bacillus 200. B. Proteus 30. C. Morgan 200. D. Bacillinum 200.
Because only that is in the syllabus, I believe. So now just 5 more questions to go.
The body fluid of Drosophila and other insects is called A. Hemocoel. B. Hemolymph. C. Blood. D. Plasma. Which hormone is called the satiety hormone as measured in the research? A. Ghrelin. B. Oxytocin. C. Vasopressin. D. Leptin. Biggest cause of kidney failure in India? A. Diabetes and hypertension. B. Drug abuse. C. Renal calculi. D. UTI.
Wow. So 2 more questions, last 2 questions.
Why are concomitants valuable in menopausal case taking? A. They distract from the main symptoms. B. They help in rubric selection and individualization. C. They are not relevant in menopause. D. They are only used for acute conditions.
Wow, good. I request Dr. Prabhukaran, if he is there, to kindly come here because the last question is going on.
Which factor was commonly observed across many couples in the study? Dr. Sandhya. A. Genetic abnormalities. B. Emotional and psychosocial stress. C. Chronic infections. D. Thyroid carcinoma.
Now everybody has caught up. Dr. Prabhukaran is here. Please, sir, please come. And Dr. Jayesh also, please. I'll request Dr. Prabhukaran to declare the scores.
Congratulations to the winners of Father J1 quiz. Third prize, Dr. Fatima MM. Dr. Fatima MM. Please do come on to the stage. Second prize, Megha and Joe. Please do come. And I welcome the winner, Fatima Fida.
All three of you, please meet me after. Yeah, please come. We'll have a photo.
Congratulations to all the winners.
Congratulations. It's amazing to see what kind of brains Father Muller has. Amazing. Keep it up, boys and girls. Keep it up.
Introduce which college?
A very good morning all. I'm Dr. Fatima MM from Department of Homeopathic Philosophy, Government Homeopathic Medical College, Calicut.
Yesterday.
Hi everyone, I'm Megha and Joe from third year, Father Muller Homeopathic Medical College.
I'm Fatima Fida from Father Muller Homeopathic Medical College. I'm a first year student.
Yeah, you can give a good round of applause for the winners. Yeah, all the winners. And for tomorrow's, today end, if people are there, today we will conduct, or it may shift to tomorrow morning, depends on the time. Be prepared and listen to the speakers. Thank you. For the prizes, you can meet me later down. Okay.
Thank you, sir. With this, we come to conclusion of the open forum and the quiz session, and we shall soon proceed to the next session. I request Dr. Suparna to kindly take over the session. Over to you, Dr. Suparna.
Thank you, Dr. Lakshmi. A very warm morning once again to all the esteemed delegates, respected dignitaries, and everyone gathered here. Before we proceed further, I would like to take a moment and thank our sponsors for their support. Durga Agency, Green Tech Enviro Solutions, Ideal Chicken, Joy Furniture, Lighting Paradise, Lifeline Surgicals, Melina Electricals. We now move to our first scientific session of the day, a session that promises to broaden our horizons and enrich our understanding as research, a session that promises to broaden our horizon and enrich our understanding as research, learning, and clinical experience come together. This platform stands as a celebration of shared knowledge, thoughtful inquiry, and the collective pursuit of excellence in homeopathic practice. It is my privilege to welcome the distinguished leaders who shall guide today's main session. it gives me immense pleasure to introduce the moderator of this session, Dr. Dheeraj Samuel. He's a distinguished homeopathic physician with over 27 years of clinical experience in Coimbatore. He is the former National Secretary General of Indian Homeopathic Medical Association and one of the directors of Zomeo. Dr. Dheeraj is an esteemed alumnus of Father Muller's Homeopathic Medical College, where he completed his undergraduate education in 1997. He went to pursue his post-graduation studies in Materia Medica from Sheikh Homeopathic Medical College, Belgaum. We are privileged to have him with us today. A warm welcome for you too, sir.
Yes.
We are equally privileged to have with us Dr. Manjula S. Haleholi as the chairperson for this session. She is the professor and head of Department of Homeopathic Pharmacy at Dr. B.D. Jatti Homeopathic Medical College, Dharwad. With over 23 years of clinical experience and 20 years of teaching, she is a renowned research guide, author, and editor of Homeopathic Science Frontiers. She has been a respected examiner and resource person for RGHS and has played a key role in curriculum development and faculty training. We are delighted to have us chair this session. A warm welcome to you too, ma'am. At this juncture, I invite Dr. Manjula, our chairperson, to take the proceedings forward and introduce the esteemed speaker for this session. I would request the chairperson to introduce the first speaker, Dr. Ashley Roche.
After Ashley Ross, you interrupt.
Immediately after this.
A beautiful morning to one and all. Moving on, happy learning and exploring the second day of EXPLORA 2025. Welcome to the scientific session. It is indeed my privilege and honor to introduce international speaker, Professor Ashley Rose, Head Department of Homeopathy, Durban University of Technology, South Africa. Professor Ashley Rose is an international recognized authority in the field of homeopathy, currently serving as a head of the Department of Homeopathy at Durban University of Technology, South Africa, with over 30 years of clinical experience and 25 years of teaching and research. He has made significant contributions to the advancement of homeopathic philosophy, materia medica, and clinical research methodology. Professor Rose is renowned globally for his expertise in homeopathic provings and has presented his research in more than 15 countries. He has served on the Allied Health Professions Council of South Africa. He has served on the Professional Board of Homeopathy, Naturopathy, and Physiotherapy. He currently holds prominent international positions as Secretary for Research at Liga Medicorum Homeopathica Internationalis, that is LMHI, and Trustee of the Homeopathic Research Institute, UK. Today, Professor Ashley Rose will be presenting on the topic, the multi-center reproving of Bacillinum burnet, informing the clinical application of the tuberculinum, where he will discuss groundbreaking findings from collaborative global study, offering new insights into the clinical relevance and therapeutic implications of Bacillinum, tuberculinum in modern homeopathic practice. Sir, kindly.
Thank you. Good morning, colleagues and delegates. Sincere thank you to Father Muller Homeopathic Medical College and Dr. Prabhu Kiran, particularly, and GHF for this kind invitation to bring me to Mangalore. I'm thrilled to be able to share particularly the reproving of Basilinum with you. So by way of introduction, I've been in practice for some 30 years, and in the treatment of most chronic cases, there will be the need for the application of some sort of nosode. There are other indications for nosodes which your teachers have already taught you. But one of the nosodes that I've used historically a lot, particularly in pediatrics, has been tuberculinum. And I'm not sure that everyone is, it's not working. I'll do it the old way. I'm not sure everyone is aware of the history of tuberculinum and even the controversies around tuberculinum. So just as an introduction, it is Herring who in 1833-34 suggested the use of a nosode of tuberculinum, of tuberculosis, which he suggested was Thyssen. But it was not until 1870 and thereafter that Dr. Samuel Swan actually manufactured a tubercular nosode, applied it clinically, and he called this remedy tuberculinum. Kent in 1893 prepared a tuberculinum remedy, which was called tuberculinum bovinum Kent. Most of us call it Tub-Bov. And you can see there from his quote in 1903 that he speaks of the specimen that he prepared or had prepared by Borica and Tafel. And he says there have been tested in hundreds of cases and many provings have been made. And I think for all of us, there is an assumption that we have a very solid and robust proving for tuberculinum somewhere. However, when we look to see if there are provings of tuberculinum, we find described by Thatcher in 1912 that by 1874 we find only records of fragmentary provings and the tentative use of tuberculinum in homeopathy, and that a complete proving of the nosode has never been made. This was somewhat of a contradiction repeated by Kent. In 1905, you'll remember in 1903, he said that many provings have been made. In 1905, he said it's hoped that the proving may be made so that we may be able to prescribe tuberculinum on the symptoms of tuberculinum just as we would any other drug. So clearly by that stage, there hadn't been a substantive proving. So where does our understanding of tuberculinum come from? Of course, we have clinical experiences, those of Burnett, and Herring describes in Guiding Symptoms case histories from Biegler, Boardman, and Swan. So this is sort of pulled from clinical experience of the remedy rather than provings itself. There were some provings done. In 1879, Swan conducted a proving on 2 provers, which yielded only 7 symptoms. Bucock, somewhat later, another 30 symptoms, Stratton, 25 symptoms, and Westner, 6 symptoms. And then there is also some supplementation from descriptions of treatment of the sick using the nosode, Clark speaking of injections of tuberculinum Koch, and Nabel, French Nabel, speaking about tuberculinum residuum in a 30C. So already there's some sort of question of what is this picture of tuberculinum actually based on. The situation is further complicated when we say, well, what is the remedy that we call tuberculinum made of? Because there are 14 different preparations of tuberculin remedies, tuberculinum in some or other name, but not necessarily derived from the same source. So we have the tuberculinum that Swan did his initial proving on, which consisted of the contents of a freshly ruptured tubercle of a patient in the final stages of TB. We have Burnett's bacillinum, which is the same, but it included surrounding pulmonary tissue of a patient who had died of TB. We then have what is called tuberculinum bovinum, which is the tuberculous gland of a slaughtered cow, so a somewhat different source. The French Pierre Jousset, did a proving of tuberculinum aviaire, which is a sterilized extract of avian tuberculosis. We have tuberculinum Koch, which is a culture of the bacterium itself in glycerine. Tuberculinum residuum, a dried and pulverized culture of the bacillus. And then we have tuberculinum or bacillinum testium, which is made from a tuberculous human testicle, and then 7 other preparations of tuberculinum of various descriptions. So when you order from the pharmacy tuberculinum 30, which one are you ordering? So this is an interesting sort of backstory introduction on tuberculinum. It used to be clear yesterday, today not so clear anymore. So how we get to the story that I'm talking about today is that you will have heard in my bio that I've been very involved in homeopathic provings, having participated and conducted provings for some 25 years. And in 2014, the LMHI, Liga Medicorum Homoeopathica Internationalis, and the European Committee for Homeopathy, each of them had guidelines for homeopathic provings, and we decided to harmonize these guidelines. And we released in 2014 the LMHI ECH guidelines for homeopathic provings. And the then president of the LMHI, Dr. Renzo Galassi, suggested that as a first test for this guideline, that we should conduct a multi-center proving of a substance. And so we decided that we would, he would control which substance was actually selected so that no one involved in this multi-center proving would have any idea what was being proved. We would conduct the proving in 5 sites: South Africa, India, Argentina, Italy, and Mexico. There were 4 main objectives of the proving, which I'm not going to go into. Many of them were not able to be achieved. But you will note that the proving was to be conducted simultaneously in both hemispheres. So we had summer-winter alternation. You will note that there are language differences across these countries, although English was the language of the proving. You will also notice that there are huge cultural and religious differences. So amongst those things we were interested in was symbolism that we see in provings. Whether if I see a lion in a proving, whether it is a lion specifically or whether it is a wild cat. So maybe in India you'd see a tiger, and in Mexico they'd see a jaguar. So there were a whole set of things that were of interest. Anyway, the process was that we would, from the LMHI ECH guideline, we would develop a single protocol which would be applied with a shared set of documentation across all 5 sites. And then a remedy would be prepared by a single manufacturer and sent from a single batch and sent to each of the 5 countries that would implement this proving at the same time. So this was in November 2017 through to February of 2018. So in the end, we had 60 provers. And we administered either a C30, a C200, or a placebo. And we received reports on 54 provers in total. So the multi-center proving highlighted a number of interesting things, one of them being quite simply whether people could follow a single protocol in the same way. So we actually ended up with a slightly varied data set. But we ended up with materia medica from all 5 countries, and we converted those to rubrics using a single defined methodology. And so we were able to then compile these 5 sets of rubrics and produce a composite repertory. So we now had a repertory of the substance. It was only at this point that we were told what the substance was. So we had developed an entire materia medica and repertory of a sort of unknown substance. And we were then told that the remedy was, in fact, Bacillinum burnet. The reason it had been chosen was because of the controversy about tuberculinum and an idea that Bacillinum itself has a relatively short materia medica, and it may, in fact, overlap with tuberculinum, but we didn't know for sure. That was Renzo Galassi's logic in any case. And so we took this Bacillinum burnet and we compared it to what exists in the repertory, and we used Synthesis Adonis that had just come out on Radar Opus, and we compared the rubrics that we had in our composite rubric list to what was in Synthesis Adonis around both tuberculinum and Bacillinum. To what extent do these 2 remedies overlap? And so we created some sort of tabulation of each of the rubrics that we had come up with in the proving and how it related to both tuberculinum and Bacillinum. It goes into many, many pages. So if we look at the traditional materia medica of Bacillinum, it's really, if we take it from Borica, which is a fairly okay source, you can see that Bacillinum has fairly sparse but somewhat characteristic symptoms. It has nice relationship remedies, complementary. There's a reference at the end to a relationship between Bacillinum and Sorinum, reference to Bacillinum testium at the end. We don't use Bacillinum that much. Mostly we use it in the context of ringworm, I think. So what comes up when we go into the materia medica that came out of a proving conducted in 2017? So what I've done is I've summarized the materia medica that came up, but you will see as we go through it that there are a large number of symptoms that we would typically associate with tuberculinum rather than Bacillinum. So the absent-mindedness, the inability to concentrate, the confusion of mind, the disinclination to speak to anyone, anger from slightest contradiction, anxiety about the future. These are all things that we would naturally associate with tuberculinum rather than Bacillinum. It was interesting to see as well that anxiety, particularly about money matters, is described as a Bacillinum symptom historically. So morose brooding, I do have copies of the materia medica that I've brought along with me, so the first 20 people will be able to get some. Feeling of mental restlessness, which is very much the tubercular indication, desire for company and affection, loquacity, mental clarity in the evening and at night, indifference to loved ones, senses heightened. The amelioration from music we see as a tuberculinum symptom rather than a Bacillinum symptom. Clumsiness also appeared in the proving of Bacillinum. In the head, we see a range of symptoms. I'm not going to read them all out, but hammering pains in the forehead appears in tuberculinum, aggravation in the morning and for motion, pressing pains as from a band. The modality of better for external pressure we also see in tuberculinum, frontal pains, headache with hyperacuity of the senses. You see the link there to the hyperacuity of the senses in the mind that we've just spoken about. Alopecia areata was an interesting one. It's not described in the classic description of basilinum, but it has some sort of link to our understanding of ringworm, perhaps. The hair being more dry, dandruff, this is tuberculinum sticking up. In the eyes, we have reddened edges of the eyes like conjunctivitis, feeling of heaviness in the eyes, objects appearing to be slightly out of focus, styes, pterygium. In the ENT, we have eczematous dryness of the auditory meatus, which does appear in the original description of basilinum. Catarrhal congestion, which we see in tuberculinum, violent itching and sneezing at night, gray or greenish crusts inside the nostrils at night, also appearing in tuberculinum as classically described. Redness of the throat with sore pain is in basilinum. So you can see there's a mixture of confirmation of basilinum symptoms with an extraordinary, actually, number of symptoms that we see as tuberculinum, which is coming up in this proving, very controlled, systematic proving of basilinum from a single source. Dryness and cracking of the lips, in the face, eruptions of pustular acne on the forehead. These are symptoms that we would think of in patients certainly needing tuberculinum as an intercurrent, as opposed to necessarily tuberculinum itself. In the gastrointestinal symptoms, we've got dryness of the inner side of the lip, painful ulceration of the tongue, bitter taste in the mouth, particularly at night, feeling of heaviness after eating, bilious vomiting, indigestion with sour and offensive irritations like spoiled eggs. Also in the GIT, sensation of hyperacidity in the morning, on waking, compulsive need to eat in the evening, a thirst for large quantities of cold drinks, which ameliorate abdominal distension, cramping pains, particularly in the umbilical area, stitching pains in the rectum, which we have in basilinum, not in tuberculinum, dry and dark brown stool in tuberculinum, diarrhea at 4 in the morning accompanied by nausea and passage of offensive flatus, which is in the original description of basilinum. Urogenital symptoms, we have increased sexual desire in men, frequent and prolonged erections appearing in this proving, but described in tuberculinum. Menses early, scanty, and of short duration, and discharge of transparent or cream-like mucus with offensive odor being the tuberculinum overlap. Chest, increased heart rate and pain in the precordium, somewhat to be expected. And in the back and extremities, we have stiffness and cracking of joints of the lower limb, tearing pains in the muscles of the lower limb, cramping of the calves. In fact, in this proving of basilinum, there was a lot of symptomatology expressed in the lower limb for whatever reason. Eczematous eruptions on the feet, dryness and cracking of the skin of the hands, and burning heat in the palms of the hands, all tuberculinum symptoms. Sleep, of course, we recognize these as being miasmatic expressions as well as being described under tuberculinum. And you start wondering, with the question around what is the materia medica of tuberculinum derived from, we start seeing these sort of miasmatic overlaps with actual materia medica. How much of it is from provings, how much of it is just a translocation of a miasmatic understanding into a supposed materia medica. So insomnia from persistence of thoughts, waking at 3 in the morning, and dreams of travel. We know desire for travel. We've got tuberculinum, calcphos, and basilinum also. Skin, there's nothing really that overlaps with tuberculinum, but maybe some sort of link to the skin manifestations that we understand of basilinum. Eczematous and pustular eruptions, hair falling out in asymmetrical patches, and profuse and sour perspiration from slight exertion being the most common. And then interestingly, almost all of the generalities take note of the desire for chocolates, sweets, farinaceous foods, fats, and spices. They all came up in the proving of basilinum, and all of them are very typical desires in our traditional understanding of tuberculinum. So what does this mean? The reproving of basilinum, thankfully, because there is a question around this, I'll speak a little bit about that. The reproving of basilinum demonstrated an overlap of some characteristic symptoms with the traditional basilinum symptomatology. So one of the challenges in homeopathy is that very often when we reprove a substance, we don't end up with the same thing. And there have been attempts in recent years, for instance, to reprove very common remedies like belladonna or arsenicum album. Harold Wallach in Germany has done both. He's reproved belladonna and reproved arsenicum album. And while you do get some sort of overlap of symptomatology, very often the expression of that symptomatology is fundamentally different because we live in a different age and we speak in a different language, and the concerns of our age may be different. So for instance, if you look in the repertory desire to get into nature, most of the remedies in those rubrics are modern remedies, remedies that have been proved in the last 20 or 30 years. It wasn't a prominent rubric in the time of Hahnemann or Hering because there would be naturally less of a desire to get into nature. But in the 21st century, we are so disconnected from nature and so disconnected from natural cycles that you can see that in the proving suddenly people, because they're reflecting on themselves and they go inside a little bit, they suddenly start feeling this desire to get into nature. And when every second proving yields a desire to get into nature, one has to then start saying, well, is this the substance? Or is this the proving process? Or is this just a product of the age? Which gives a whole new dimension to provings. So having a proving of basilinum, or at least a materia medica of basilinum that is at least 100 years old, when we do a reproving, and we do a reproving in multiple contexts, very different contexts, and we get an overlap, which is quite significant, with not too much contradiction, that in itself is a good sign in terms of looking at the methodology that was adopted. But perhaps more enlightening in this particular experiment is that there are a large number of typically tuberculinum symptoms that were produced in the reproving of basilinum. And this supports two historical observations. One is that the existing tuberculinum picture is imprecisely derived from multiple and varied sources that I described beforehand. It's not nearly as clear as all of us carry it in our hearts to be. And also that many of the symptoms of Burnett's basilinum have been and I put in brackets incorrectly, incorporated into the understanding of Kent's tuberculinum. And prior to this, I had understood that many of the rubrics that had come from Basilinum, from Burnett's work with Basilinum, had been incorporated into Kent's repertory and put as tuberculinum. So I was aware of this challenge, but I wasn't quite as clear in understanding that. So this was really quite a revelation for me, to actually see the extent to which so much of what we understood as tuberculinum was in fact Basilinum. And so I think this is a very useful thing because it allows for both the clarification and the expansion of the remedy picture, and more importantly, certainly in my own experience, a more precise application of the remedy in clinical practice. So I've used, as I said at the beginning of this talk, I've used tuberculinum bovinum a lot, particularly in pediatric cases. At this point, I am almost, as a first response, prescribing Basilinum to these same children with much better results, actually, than using tuberculinum bovinum. Other authors have suggested this in the past, that maybe Basilinum should be used, particularly in pediatric cases, rather than tuberculinum bovinum. But because I understand Basilinum as a much bigger remedy now, and I understand that so many of what I would almost have regarded as keynotes of tuberculinum are in fact in Basilinum, I've preferred to go to Basilinum. In some ways, we have a reliable proving of Basilinum, and we don't have a reliable proving of tuberculinum. And so from that perspective, it makes more sense almost to prescribe Basilinum rather than tuberculinum, but I've certainly seen an increase in the response under Basilinum. I'm not suggesting that every case of tuberculinum should have Basilinum, but it's certainly food for thought. So with that, just an acknowledgement of the other 4 proving directors in each of the countries. Dr. Agustin Salinas in Argentina, Dr. Takeshwar Jain here in India, Gustavo Dominici in Italy, and Dr. Rosario Sanchez Caballero in Mexico. Thank you for your time.
Thank you, sir, for your insightful take on reproving of Basilinum and clinical application of tuberculinum. Your words have truly added immense value to understanding and practice of these remedies. May I now request Reverend Father Donald Neelicrasta, Administrator of Father Muller's Homeopathic Medical College, to kindly present a token of gratitude to Dr. Ashley Ross. Thank you, Father. Thank you, sir. Before we continue with this proceeding of session, I would like to announce that there will be an auction ceremony. We are delighted to present a very special event today, the live auction of the Zomeo Elite software, one of the most advanced homeopathic digital tools available. To make the process simple and seamless for everyone, we request you to scan the QR code that will appear on the screen. This will take you to a dedicated WhatsApp group created exclusively for this live auction. Then you scan the QR code, join the WhatsApp auction, and get ready to place the bids once the auction starts.
A very good morning to ladies and gentlemen. Welcome to this exciting moment at EXPLORA 2025, the International Homoeopathic Conference. Up for auction today is something truly special, Zomeo Elite, the premium homeopathic software from Homepath, trusted by practitioners around the world. So what is so special about this software? So the speciality of this software is, this isn't just a software. It's a digital companion for accurate prescriptions, deeper insights. With 12 repertories, 805 volumes of books, and 21 expert webinars, Zomeo Elite empowers you to find the right simillimum faster, smarter, and with precision. So what do you think? It must be very costly, right? It is actually. The actual amount of this Zomeo Elite is 23,000. But today, we have brought this to you from the baseline of 10,000. So you can scan the QR code which has been displayed on the screen, and the auction will start soon. The auction is open. You can start bidding in the WhatsApp group, which you will be added after scanning the QR code. It's just 11K, 15K, 15, 5, 13K. We'll ask MC to join. Take the mic and come and share the mic.
Yeah, we are excited to see the bids coming in. Kishle, and we have Gnanam Priyan. Kishle is now with 15,500. 15,500.
So anybody is there who want to compete?
Hello, are you able to have it? Good morning.
Anybody is there who wants to compete, Kishle Jain?
We go 15,000 for once, going 15,000 for twice. Okay, so now we are selling for Kishle.
I am able to hear.
Highest
But
bidder.
are you able to hear?
Congratulations, Kishle. You can come to the front stage here.
Hello.
Yeah, Kishle can come forward, yes.
Kishle Jain.
But from my side, it is okay.
One second.
Excuse me. Yes, there is a higher bidder now.
After it is sold, they have come for 15,600. That we will take for the next count, sir, now. So we have another bidder, Dheeraj Samuel, sir. He is sitting here. Now we have another one, 15,600. Count of one. Anybody? Above 15,600?
15,600.
Second.
Going once. 15,600. 15,600 for going twice. Anyone wants to go for higher bidder?
Anyone is going to compete? Yes, the auction is getting really excited now. So 15,600 once, twice, and congratulations to the proud owner.
And we have the second winner for this morning, Dr. Dheeraj Samuel with 15,600 rupees.
I'll give me applause.
And now you can continue bid for the third one. Again, the base price is at 10 for the third software of Zomeo Elite. You can start. Okay, we have
The first bidder.
The first bidder with 13,000. 13,000.
Yes, they're typing.
13,000.
Hello, good morning. 1, 2, 3.
Anyone wants to bid for more price?
The rule is the highest bidder will win it.
Yes.
So the more you bid it, you all are bidding it at the lower price. The highest bidder should win it. So you should increase it. I actually tried to help you all increase the amount. You all gave it to me.
Okay, we'll count.
Still coming on. So going for 13,000. Anybody is going to compete? For 13,000 once. For 13,000 twice. Congratulations to the 13,000. Now this one, 13,000, it will be sold. Thank you so much. Have a great day ahead.
Before continuing, I would now request Dr. Lubna to make a few announcements.
Thank you so much. Good morning, everybody. It's my honor, my teachers are here, so it's my honor to hand over these books, my book, I mean the first book, to my teachers. Dr. Ishwar Das, sir, please come here. Dr. Subhash Singh, sir, please. Thank you so much, sir. Thank you. Dr. Prabhu Kiran, sir, please. Dr. Prabhu Kiran, sir. Sir. Dr. Praveen, please may I hand over my book to you, the first book.
Thank you, all the best.
Thank you so much. No, please go.
Homework, good luck, we'll respond. Thank you. All the best. Thank you.
We will now continue with the scientific session. I would now request our chairperson to introduce the next speaker, Dr. Venu Krishnan.
Please join me in welcoming our next speaker, distinguished homeopath, known for his commitment to holistic cancer care. Dr. Venu Krishnan, Chief Medical Officer, Department of Homeopathy, Government of Kerala, Honorary Member, Homeopathic Education Board, National Commission for Homeopathy, Ministry of Ayush, and Government of India. Dr. Venu Krishnan is a distinguished clinician, researcher, and educator in the field of homeopathy, recognized for his pioneering work in integrative oncology. He is currently pursuing his PhD at Vinayaka Mission's Research Foundation, Salem, focusing on molecular profiling of homeopathic formulation for stage 4 lung cancers. His research integrates molecular science with homeopathic principles to explore targeted and evidence-based therapeutic approaches in cancer care. A visionary in healthcare policy, he advised with and established the first homeopathic cancer inpatient center in the Indian government sector, advancing integrative oncology within public health. Today, he will be speaking on the topic molecular profiling of homeopathic formulations in lung malignancies, where he will discuss translational research insights into the molecular mechanisms of homeopathic medicines, their potential in modulating the tumor microenvironments, and implications for future cancer therapeutics. Sir, the stage is yours.
Thank you.
This one, sir.
Good morning. Respected Chair, esteemed dignitaries on and off the dais. So let me draw your attention to a different topic apart from homeopathic conferences, which can make trailblazing thoughts, or our student, young generation shall extrapolate their mind to the future validation of scientific community. Most of the times, even when homeopathic clinical stories have touched the lines, unfortunately, we may be unable to make a translational explanation in black and white. That means unsuccessful validation in the material world of science. So this is an attempt to bridge the subtle homeopathic concept into the molecular vocabulary of oncology. This is a very large topic. Usually it is an elusive topic, but the poignant question here is, we should be validating, we should be talking in the language of science. So mechanistic studies of arsenicum iodatum in human lung cancer cell lines was the topic, A549. The cell lines can be procured from companies. Any of the student can do this topic. No need for a PhD to do. These are basic scientific experiments, and we are trying to seek whether a molecular explanation can be given to our medicine's acting level, the modus operandi. The background and objective is clear. Lung cancer is the leading mortality cause. And we are having multifaceted therapies, chemotherapy, radiation, targeted therapy, hormone therapy, immunotherapy. But whether these therapies are non-cytotoxic, we need cytostatic, not cytotoxic therapies. We need integrative therapies. And we belong to a noble class of integrative medicine. So how can we talk in the language of science? How microdoses can evoke macrobiological response? We need explanation of biomedical, physical categorization of homeopathic medicines. These were the assays considered. I told you, these are complex assays, but just to have an idea, preliminary cytotoxic and growth inhibition assays, including MTT assay, then cell cycle and apoptosis determination through flow cytometry, RT-PCR, apoptosis by annexin staining, then mechanistic and molecular test to identify the cell signaling pathways or cell cycle inhibitors. transcriptional changes in pro and anti-apoptotic cell cycle. So first, we did an MTTSA. Our potencies selected was a spectrum of starting from 6C, escalating into 12, 30, and 200. 4 potencies with a biological control and additional control of ethanol, extra neutral alcohol, was also taken, because whenever we speak of some results, there should be validation with a control. Here, biological control is not the basic thing. We need an ethanol because our medicines are being dispensed in extra neutral alcohol or ethanol. So whether alcohol is causing the cytotoxicity or the cell viability is influenced by the vehicle, that has to be delineated. These are complex graphs just to have a just idea, a bird's eye view. When we did 6C potency, it showed a cytotoxicity at the 50 micromolar concentration. Then 12C, 30C was done, and 200C. And this is the composite graph. You can identify with the color. Vehicle is being plotted in the blue. It shows a marked variation in the inhibitory concentration or lethal concentration. Whenever we do an MTT assay, LC50 value or IC50 value should be taken. And IC50 value means, or LC50 value means, a solvent when added, an agent is added to a solvent, whether that agent could kill 50% of the cells. And that is the demarking thing, LC50 value or lethal concentration. So these were compared, and from this, we could analyze or we could understand these results were not at all due to the solvent and was solely due to our potencies. And that too varied from 6C to 200. And it is a brain thought-provoking or mind-blowing thing that even before, 200 years before, Master was able to enunciate these type of complex mechanisms. Even when biochemistry or biotechnology was not there, he was able to prevision these type of variations, like the variations in music, the saptaswaras. Even though music is the same, the meter changes. So I think homeopathic meter is getting changed by each potency, and each potency is having a vivid range and profound action. So what is the conclusion? It can demonstrate significant anti-cancer potential. Higher potencies, 30C and 12C, produce maximum cytotoxicity with minimal non-specific toxicity. So we should understand apoptosis. What causes this? That's how we next move to apoptotic studies. Or before that, cell cycle analysis. This is a slide just to give an idea what is happening in cell cycle. Actually, cell cycle is the basic harmonious, organized program beautifully orchestrated by the vital force. What we learn in aphorism 9, it actually points to this. The S phase, G phase, M phase. When these phases are going in harmony, no pathology will occur. But whenever there is a change, a mutation can happen, and thereby uncontrolled proliferation or unwanted aggravation can come. For that, just an idea. I think there was a question from this also. DNA replication is happening in which phase? So how our medicine is capable of acting a significant or an indelible mark in the cell cycle? Is it possible? That's our study. So this is also a composite graph where we did every experiment twice to avoid bias. And we got the result. I had plotted with this picture because just to have an idea where each potency is having an action. See, 200C is having a G0, G1 stage. G0 means the quiescent stage. 0, 0. No growth, everyone okay. Start, proto-oncogenes starting their action. Cell started dividing. First, DNA getting fragmented, organelles getting fragmented, 2 cells are coming, then going into mitosis, stop. Again G0, it's normal. But from G0, if it's again going to uncontrolled proliferation without an orchestrated signal from the top, that means proliferation. So how each medicine, each potency can influence these phases is plotted here. We did a comparative flow cytometry analysis. The left end shows the control graph. The blue picture, always, that's a histogram distribution is being shown. Blue shows G0 or quiescent G1 phase. And the green shows the synthetic phase. And the magenta is G2 or mitotic phase. So each potency change can be clearly markable, which can make extrapolated thoughts for further studies. If our medicine is capable of influencing such a dramatic cell cycle change, definitely our answer is on the way. We will see. See, the vehicle-treated cells show 40.4% of G0, G1, 11.3% of the synthesis phase, and 40% the G2 M phase distribution. Comparison with potencies revealed reduced proliferation and increased apoptosis at higher potencies, 30 and 200. Vehicle group, alcohol maintained a proliferative pattern because it was validating the cytostatic effects. Always, we should be able to delineate between a cytotoxic activity and a cytostatic activity. Cytostatic activities should be welcoming. Always alcohol do things with necrosis, and our medicine won't do necrosis. It will promote apoptosis. So next we did apoptosis. For apoptosis, there are multiple methodologies. Here we used annexin 5 staining. It's a sophisticated technique and a costly technique also. So whether our medicine in each potency is capable of influencing a pro-apoptotic stimulation, an anti-apoptotic, or a late apoptotic. That was our idea. See the right thing, late apoptotic or dead cells possible due to ethanol stress. This can be clearly marked in each potencies. 6C, when was used, it showed an early apoptosis, while 12C showed a late apoptosis. Coming to 30, late apoptosis or dead, and 200C, loss of measurable pro-apoptotic signal. Apoptosis was stopped. And this is another thought-provoking, mind-blowing schematic point, whether next level of research should be thinking. Because 200 potency is an ideal moderate potency, we used to say. There, the body harmonizes. Harmonizes means it has regained its physiological equilibrium, which is welcoming in a case when treated clinically also. What we expect clinically, each and every patient, we need a regain of physiological stabilization, or rather physiological optimization. That's our motto. So 200 potency is showing a stabilization. So this is the interpretation. You can see the control. Control means it's a biological control. Baseline live cells, then vehicle is there, slight stress response. 6C is showing early apoptosis. 12C is having an enhanced apoptosis, and a late apoptosis by 12C 30, and 200 is having a declining effect. Because the cell recognizes the presence of an invisible orchestrator to do and not to do, when to do and what to do. What will happen if 1M or 10M is being tested? These are under pipeline. Maybe in the next coming months, I may be able to, fortunate enough to draw the results. So this is the histogram analysis of annexin Y positive apoptotic stage. always, when we plot things graphically, use histogram distribution for more clear statistical explanation and scientific validation. Then we move to cell migration assay. What is the relevance of a cell migration assay? Whether the agent or the medicine is capable of drawing the wound closure. Is it possible? Is it possible with medicine, and what difference it makes with each potencies in the cell migration? It's a beautiful assay. Numerous pictorial figures are there. Because of time constraints, I am unable to portray all those things. Just to understand whether our medicine is having, whenever we say our agent, Arsenicum adatum, is having an anti-cancerous property, it should mean that it should have a metastatic, anti-metastatic property also. So anti-metastatic property is being enunciated by or being proclaimed by this cell migration assay. That is the significance. Signaling pathways, mTOR pathway, PAKT pathway, these are the basic pathways which the cell formulates, cell cycle signaling and the whole thing. So whether our medicine is capable of making a significant change, that is the question. So this is the graphical plot. 6C showed a treatment inhibition 70.1, 12C getting low. Again show, see 200 is having a distinctive effect and the vehicle is having another value. This can be plotted again in the histogram distribution with accurate, clear-cut explanation that Arsenicum iodatum is having an anti-metastatic potential, and that too in various potencies, in various spectrum, and that too in variegated effect. So how can it be summarized? The rate of wound closure was lower. The p-value has to be determined. It is less than 0.001 compared with the control. So a time and potency dependent variation was clear-cut. First, cell viability showed a potency dependent change, and here a time and potency dependent. See the thing? 10 or 15 years before, we can't think of scientific validation. But fortunately, numerous journals, peer-reviewed index journals, publish these type of validation, apoptosis, cell cycle inhibition. Students should be in the habit of going through peer-reviewed journals at least twice or at least once in 6 months in your postgraduate studies as well. Because peer-reviewed index journaling, don't think that our article will be getting published at the first time. No. First, we should be reading articles, how these are being manuscripted, what all tests are being done, and how we can also be a good researcher. So a time and potency dependent variation was evident. Next, our assay was autophagy. Autophagy means that shows the ability, whether the cell is capable of doing the thing. Autophagy, we use an LC3. LC3 is a biological marker. These are complex biochemical things which may not be clear to a student like our community. But the thing is, these type of biological markers, when get tagged with our medicine and undergoing these type of intricate assays, it will give some result then that is really heartening. So we got a result with the mean LC3 intensity of control group, then you can go through the variation also. This can be histographical. The distribution can be shown like this, LC3 intensity histograms. With the color, that biological control is the top, Then coming to 6C, 12C, 30, and the blue is 200. Here what we got is a right shift of LC3. A right shift means our medicines are capable of promoting an autophagy induction. An agent, when administered to a solvent or when administered to a cell or a cell line in vitro, whenever is capable of going for a right shift in LC3 means definitely that therapeutic agent is having an autophagy induction. What we get clinically each and every day across the homeopathic diaspora, the whole country, what we are getting results clinically. Even a single prescriber to this type of complex organized colleges. This is happening, but we are unable to say why and how and who is doing these things. So these type of researches, this type of study should be our foundation in the coming years. These type of conferences shall converge with an idea that science should blend with art. The next essay was clonogenic assay. This assay is also capable of proving whether an agent is capable of making colonies. Colonies means that is the physiology. Whether our medicine could significantly impact, that's a picture of a clonogenic assay working schedule, just to have an idea. Here what we got is a dose-responsive trend. A dose-responsive movement means the agent is acting. How can we plot this clonogenic assay? The blue line is vehicle, then the color, each and every potency is having a distinct and categorized change in that autophagy. With all these studies, what we do? So these are some gist that Arsenicum iodatum is capable of working its mark. Then how can it be validated in our gene expression or protein expression? So that we need mRNA studies. Whether our medicine is capable of going further, we need proteomic signaling. We need ICP-MS, inductive coupled mass spectroscopy. And that is not available, it's only available in QSAT, Cochin University of Science and Technology. I did my experiment there, and fortunately, we got breakthrough results. The next study is atomic coupled inductive plasma mass spectroscopy, which is only available in NIIT, Chennai, and which is very costly also. For a singular researcher like me, can't afford the cost. But discussions are going on the way whether to continue with the results what we got in ICP-MS. I have not included ICP-MS study in this because of the time constraints. So moving on to mRNA expression. It's a complex thing. Just giving an idea. We are having an axis, P53, P21, and P27. Everyone may be knowing about P53, that's a guardian genome, which is watching us like the creator, like the benevolent creator, the merciful. The P53 is the guardian genome, guarding on all circumstances. Whenever this gets a mutation, maybe a radiation, maybe an emotional trauma, maybe an accident, maybe a cytotoxic treatment, this guardian genome lose its control. Then the whole axis, P53, P21, and P27 gets disrupted, disharmonized, resulting in uncontrolled cell proliferation and unwanted natural cell growth, which can influence in the signaling pathways, making a catastrophic event. Terminal nomenclature called cancer. Yes. So this also modulates in a potency-dependent biphasic hormetic manner. Here also, a graph will give you a clear explanation. See, BAX, P53, and caspase 3, these are the apoptotic markers. See, this should be upregulated, and BCL2 should be downregulated. Upregulation of BAX, P53, and caspase shows it is having anti-tumorous property. And it should downregulate BCL2, which our medicine did. And this is a composite graph. It's clear from the graph. Because of time, I'm skipping. So this will give you a better idea. Relative gene expression changes in A549 with arsenic amide item, control P53, BAX. BAX, P53 and caspase should be upregulated while BCL2 should be downregulated. So what is the conclusion? We got a hormetic biphasic pattern, which is a classical presentation as an inverted umbrella, a U curve. This is the standardized curve. When we do this type of studies, this should be the curve. And if this is the curve that shows low potencies can stimulate, moderate potencies can suppress, and higher potencies can stabilize. So our medicine did this wonderful thing. And the graph came out, a biphasic hormetic pattern. Homeopathic ultradilution studies, low doses, apoptosis genes, pro-operative, we got a stimulation inhibition curve. The last confirmatory test is Western blot. It's a laboratory technique to identify specific proteins. So whenever we get a result from mRNA, it should be corroborated with Western blot. Here, expression of phosphorylated AKP, PAKT, it is termed like that. That is the biological marker. And we did a Western blot analysis because the P13K or PAKT signaling pathway is the basic pathway which is influencing the proliferation, survival, and migration. So histogram distribution can be shown like this. Clear-cut, demarcated, substantiative results. Whether these micro doses can evoke a macrobiological response. This is the summary. Everywhere we treated biological control along with ethanol to delineate our results as conclusive. These are the results, B-actin intensity. So what we did, this is the compact composite slide, integrated mechanistic validations. We did an MTT assay, we got a dose-dependent growth inhibition. We did annexin 5 staining, we demonstrated apoptotic pathways. We did cell cycle analysis, what we got, identified cell cycle blockages. We did Western blot, it confirms a downregulation of PAKT inhibiting, that shows the cell cycle, cell stimulation pathways being influenced. RT-PCR showed it validates a molecular pathway consistent with phenotypic findings. So with this, let me come to the end. Whether our subtle homeopathic science, homeopathic pharmacodynamics, always being elusive, rather being shown in including Wikipedia or including scientific journals, placebo effect. So these type of results may not be a substantial explanation, but still we could move forward. Shall be a torch-blazing, trailblazing thought for young generations. Why I went for these studies? Because I am working as a clinician in an exclusive oncological center for the past 2 decades. So quite most of the times I was wondering why my patients are always also getting good survival rate, even without adjuvant therapy, even without chemotherapy, targeted therapy, immunotherapy. Our patients were also successful in completing, have a good survival rate, a good cytoreduction, absolutely with a good quality of life. Then what be the mechanism? Because of that thought, we did an in vitro validation. Now we got both an in vitro and in vivo. And this is my center, a model center for integrative oncology. Thank you.
Thank you, sir, for your nuanced and fresh perspective on homeopathy in lung malignancies. We are enriched by the wisdom that you have shared. May I now request Dr. Kurian, PJ, Professor, HOD of Department of Repertory, Yenapaya Homeopathic Medical College, to kindly present a token of gratitude to Dr. Venu Krishnan. Thank you, doctors. Delegates, please take note that the QR codes are available to access all conference photos at the MC desk, registration counter, and near the dining hall. Please scan it at your convenience. Now we transition to one of our online segment. We invite all present to stay engaged as we join our speaker, Dr. Reenu Mittal, virtually.
Welcome to the well-known research officer, Dr. Anupriya Chowdhury. Dr. Anupriya Chowdhury is a dynamic scientist and a researcher currently serving as Research Officer, Homeopathy at the Central Council of Research in Homeopathy, Ministry of Ayush, Government of India. Since joining CCRH in 2014, Dr. Anupriya has played a pivotal role in several national and international research initiatives, including studies on lifestyle diseases, the integrated homeopathy, NPCDCS programs, COVID-19 prophylaxis, school health interventions, and as an associate editor of the Indian Journal of Research in Homeopathy.
Hello? Yeah, may I share my screen now?
Yeah.
It is coming as if the host has disabled attendance screen sharing. You have to enable from there, sir. I am not able to share my screen.
Delegates who are interested to participate in OSCE workshop in Organon, Materia Medica, and focus small group discussions with Dr. Ashley Ross and Dr. Kim Jobs are requested to contact the help desk at registration counter.
For things, just let me know.
Please take note that the QR codes are available to access all conference photos at the MC desk, registration counter, and near the dining hall. Please scan it at your convenience.
Yeah, do it.
Shall I start? Good morning, everybody. I am Dr. Reenu Mittal, scientist from Central Council for Research in Homeopathy. First of all, I would like to thank the organizers for giving me an opportunity to be present just before this August gathering. One of the publications of the Council on the tinea infections, on the role of homeopathy in the management of dermatophytic infections. So, as we all know, dermatophytes are the fungi that invade and multiply within keratinized tissues like skin, hair, and nails, and thereby cause infection. So, the dermatophytes are classified on two bases. On the base of their genera, they are classified into three groups: the trichophytans, which cause infection on skin, hair and nails. The epidermophytons, which cause infection on skin and nails only. And the microsporums, which causes infection on skin and hair. And second, the classification is based on the site of infection, the part of the body which is involved. The tinea is classified as tinea capitis, which means the tinea fungal infection of hand, tinea faciae, face, the tinea barbae for the beard, tinea corporis is for the whole body, tinea manus for hand, and tinea crudis groin, tinea pedis foot, and tinea anginum nails. And the prevalence of the dermatophytosis in India usually ranges from 36 to 78%. And how to characterize the lesion in the case of tinea infections is there is a presence of an erythematous red patch on the skin that is typically very itchy, and it usually represents as a well demarcated, sharply circumscribed, oval or circular, mildly erythematous scaly patch or plaque with a raising leading edge. So usually the lesion starts as a flat scaly spot and it spreads centrifugally with clearing from the center, and it usually gives a typical appearance of a ring. So it is commonly usually also known as the ringworm. The central area is usually hyperpigmented and the borders are active. Occasionally the border can be in the form of a papular or vesicular or pustular eruptions. The incubation period for the tinea infection is 1 to 3 weeks, but it may last long depending upon the maintaining causes and the environmental factors. And whenever there is an infection, usually it is not confined to one area of the body. It tends to spread gradually to other areas. So how we diagnose cases of tinea. The objective tool for diagnosis of tinea is the KH mount test. We usually take scrapings from the fungal lesions, and then that is mounted with a potassium hydroxide solution, and we watch under the microscope for the presence of hyphae. And that test is known as KH mount test. And clinically there are many outcome scales which are used for diagnosis, the clinical cure scale. Then there is the skin index scale which we use usually for the assessment of the quality of life. There is a global evaluation response scale by which we can assess the response of the treatment to the medicine. And then is the Monarch criteria we usually use in homeopathy to establish the relationship between the intervention and the outcome. So the clinical cure scale is usually a visual scale, and it's a validated scale for the assessment of lesions and resolutions of signs and symptoms. Mainly the symptoms which are used in it is a scaling, erythema and pruritus. The score of the scale ranges from 0 to 9, where 1 to 3 is considered as the mild score, 4 to 6 is moderate score, and 7 to 9 is the severe score. Then there is a global evaluation response. This is usually based on the percentage, considering the improvements of clinical signs and symptoms, and is usually done in the case of follow-ups. And the assessment criteria is if there is a 100% remission, it is termed as cleared of all the signs and symptoms. For 90 to 90% improvement, it is designated as an excellent improvement. For good, we have a criteria to about 50 to 89% of the improvement of clinical signs and symptoms from baseline. And fair is classified as 25 to 49% improvement of clinical and signs and symptoms from the baseline. And the poor response is less than 25% of the improvement. So skin index is usually to assess the quality of life, the impact of the disease present on the quality of life, and it's a 16-item scale and has 3 domains. One is the symptom domain, second is the emotional domain, and third is the functional domain. And the score for each question ranges from 0 to 6, where 0 stands for never bothered and 6 is always bothered. Next is the Monarch criteria, which is there for the causal attribution and evaluation. And this is Monarch Naranjo criteria for homeopathy. it is used to establish the causal relationship between the clinical outcome and homeopathy, and it is a validated tool for assessing the likelihood of causal relationship between homeopathic medicines and clinical response. And the last is usually the photographic evidence, which we usually take before and after the treatments for the assessments. So these are some of the cases which have been treated, and this case series has been published in a peer-reviewed journal. So the first case is a case 1 of 38-year-old male who is a travel agent by profession and clinically presented in one of our derma OPDs with circular patchy eruptions on the back, shoulder, right wrist, buttock, groins, and for 1 year, and he was suffering from the complaint since 1 year. He had itching in the lesions which was better by warmth, and scaling and burning which was worse by scratching, and there was watery discharge oozing out of these lesions. Mentally, the patient was irritable at petty issues, and he doesn't like company, and he was religious by nature, and he had a desire for sour food and drinks, milk and bitter things. He had sudden urge to pass stools after waking up in the morning with profuse perspiration all over the body. Generally, he was uncomfortable in warm weather, and clinical findings where there were multiple annular eruptions were seen on back, shoulder, right wrist, buttock and groins, and the margins of the lesions were inflamed. If we can just see, these were the lesions. In the photographs have been shown before and after the treatment. The lesions have been cleared, and the medicine given to this patient was sulfur. Earlier in the starting it was from the 6C in 2 to 3 doses, and it was followed by sulfur 30C, and the total duration of treatment for clearing of the lesions required was 69 days. The case number 2, it was a 24-year-old male who complained of circular patchy eruptions on legs, buttocks, back, right hand, eczema for 4 months. Initially, the eruptions appeared as small papules on both legs simultaneously, and which spread over to the buttocks and then to right hand and axilla, and lastly over the face. He had itching which was worse by scratching and at evening itching was followed by scaling. And in the past, he has taken treatment to allopathic medicine for 3 months without any relief. Mentally, the patient was irritable and he doesn't like consolation. And he has a desire for bitter things, chicken, milk and green chilies. He had intolerance towards egg and chicken, and consumption of these foods products led to stomach aches and nausea. And the clinical findings were the multiple annular eruptions with erythema and scaling, and the margins of the lesions were well defined and inflamed. This patient was also given sulfur 30C and later on sulfur 6C and 30C, and the duration of treatment was 105 days. So this is the third case. It's a case of 45-year-old male who was a tailor by profession, and he had circular patchy eruptions on the left side of abdomen for 2 months, and there was a single lesion of small size which increased gradually, and then another lesion appeared, and he has complained of itching and scaling which was worse, sweating at night, and there was history of similar lesions on the groins 1 year back, for which he took mesarium and was relieved earlier. Now, and he also complained of non-specific pain on left side of chest for 5 to 6 years, which was worse in evening and better by passing flatus. And he also stated that he had palpitations when hearing good news and get anxious when hearing bad news with trembling of the extremities. Mentally, he has fear of death, and he always used to fear that something wrong would happen, and he desired company, and he got angry easily when he was contradicted. So in physical generals, he thirst for small quantities of water at frequent intervals. Tongue was moist, coated white with imprints of teeth, and generally he was comfortable in cold weather and open air. In the clinical findings, there were annual eruptions on the left side of abdomen, ill-defined margins with erythema and scaling. The medicine given was arsenic album 6C followed by 30C, and the duration of treatment which took for the clearance of all the lesions was 207 days. Another case is of 18-year-old female who complained of circular patchy eruptions on her right thigh, both arms, abdomen and back since last 2 months. It began as small papular eruptions, gradually increasing in size and became circular patchy eruptions. And there was intense itching and burning in eruptions, which was worse by scratching. The treatment history she had taken allopathic treatment 1 month back for 15 days without any relief. Mentally, she loved making new friends and felt comfortable in the company. She was soft-spoken, jovial, and fond of cleaning her surroundings and belongings. She is desired of sour food and drinks large quantity of water in one go, but her tongue was dry. The patient was chilly but with a desire to be in open air, and in the past she had a history of pneumonia, urticaria, for which she has taken homeopathic treatment with relief, and the clinically finding were the multiple annular eruptions with slight erythema and scaling present in the lesion. The margins of the lesions were well defined but not inflamed, and the medicine was given was CPS 6C, and the treatment duration of the treatment were about the 153 days. So another case of 40-year-old male was a businessman, and the clinic he presented with circular patchy eruptions on thigh and hands for 2 years. Right thigh followed by left thigh, and then to both the hands, spread then to both the circular patchy eruptions. There was itching in the affected area, which was worse by heat and sun exposure. The patient has a desire for salt and spinach and had intolerance to meat and eggs, which caused abdominal pain and bloating after eating. Clinically, multiple annular eruptions were seen on thighs and hands, and with mild erythema and scaling. The margins of the lesions are irregular and inflamed, and the medicine given to him was Solanum 6C, and then 30C and 200C was also used in this case, and the duration of treatment was 150 days for complete clearing of the lesions. So these are some of the slides of the KH mount test, the microscopic vision, which shows the presence of hyphae and then clearing of the lesions. So the discussion is all of these cases were treated with a single individualized homeopathic medicine. The sulfur was prescribed in 23% of the cases, which shows maximum improvement. Other medicines found effective were the Natramure, Sepia, Soranum, and 88% of the patients have showed improvement in their symptoms with the homeopathic treatment. There was a statistically significant decrease in the clinical cure scale from baseline to end of treatment, and 34% of the patients experienced complete clearance of symptoms. 23% of the patients showed 90 to 90% improvement in their skin lesions. The composite score of skin index 16 also has shown the statistically significant improvements with p-value 0.00, which reflects the positive effect of homeopathic treatment in patients' quality of life. And as per the assessment, the causality assessment on the Monarch criteria, there was a score of 8 in 22 cases, which indicates a possible causal attribution of internalized homeopathy in treating tinea corporis and cruris. So the conclusion from these cases, and this was a case series wherein the 26 cases have been published, and this case series have shown that there is evidence of usefulness of homeopathic treatment for dermatophytosis, particularly tinea cruris and corporis, employing clinical assessment and the standardized evaluation matrix and the photographic documentation methods. We usually ensure an unbiased, objective evaluation of treatment and patients' quality of life. So, and also the continued research using rigorous criteria like Monarch can further substantiate the role of homeopathy in managing dermatophytosis and other chronic conditions. This study has been published in Indian Journal for Research in Homeopathy in volume 18 in issue 4, and the limitation of this study was that due to comparator group and the double-blind non-availability of the comparator group, and for that a double-blind studies in the tinea infections are required for having a more meaningful data. These are the references which have been used for this presentation, and thank you so much. If there are any questions, I will be happy to take over.
Thank you so much, Dr. Inu, for sharing your evidence-based clinical insights. It will surely give a new perspective to all of us. Now we'll continue with the scientific session. I would request the chairperson to introduce our next speaker, Dr. Anupriya Chaudhary.
Welcome to the well-known research officer, Dr. Anupriya Chaudhary. She is a dynamic scientist and a researcher currently serving as a research officer homeopathy at Central Council for Research in Homeopathy, Ministry of Ayush, Government of India. Since joining CCRH in 2014, Dr. Anupriya has played a pivotal role in several national and international research initiatives, including studies on lifestyle diseases, the integrated homeopathy, MPCDCS program, COVID-19 prophylaxis, and school health interventions. As an associate editor of the Indian Journal of Research in Homeopathy, she continues to contribute to evidence-based discourse in the field. Today, she will be speaking on the topic randomized control trial in homeopathy, where she will shed a light on the design, methodology, and challenges of conducting rigorous clinical trials in homeopathy, emphasizing the role of scientific validation in advancing holistic healthcare. Madam, please.
Is it too high now?
Yeah. So a very good morning to all. And thank you very much to the organizers of EXPLORA 2025, Father Muller Homeopathic Medical College, for having me here, inviting me to present work which concerns with our latest efforts with collaborating with homeopathic medical colleges across India. So before I go ahead with my presentation, so my organization, the Central Council for Research in Homeopathy, has, under its initiative of linking research with education, recently been collaborating with a couple of homeopathic medical institutions across India. So this initiative we have started back in 2018, after which we have taken up a couple of research studies with homeopathic institutions. And this one, which I'll be presenting today, is one of the first studies that we had taken up. This study, Homeopathy as Adjuvant Therapy to Standard Medical Management in Persons with Hemophilia, was a prospective randomized double-arm study. So without going very deep into the subject, because being an academic institution, I'm assuming that everybody has a very fair idea about what hemophilia is. So I'll just quickly rush through the earlier slides, giving a background about the condition. And hemophilia is an X-linked hereditary bleeding disorder, of course, which is related with the deficiency of factor 8 and factor 9. And primarily, the deficiency results in anything like recurrent bleeds, which is ranging from superficial cuts to even life-threatening bleeds. And basically, the mainstay of the treatment is only the replacement of the clotting factor. So nothing much that we have as far as the standard care is concerned, but only the replacement of the factor that is available. When you look at the global burden of this disease, it's kind of, very, very shocking to know that the prevalence per 1 lakh males is 17.1 cases for hemophilia A and it is compared with 3.8 cases of hemophilia B. And the global population of patients with hemophilia is 3 times larger than which is what is originally believed. So somewhere, the global burden which we are assuming, which has kind of been registered so far in the global registries, is not showing the real picture because the burden is much more than what is actually registered. The situation is quite similar in India, where India, according to a recent report by the Hemophilia and Health Collectives of North, supposedly India has the second largest population of hemophilia cases in the world. And if you calculate with the prevalence that is kind of being projected for this disease, India is expected to have at least 1.5 lakh hemophiliacs. But the registries, the recent ones being, which was published in the 2022, reports only 25,000 cases which have been registered so far. So, there is a huge gap even at the level of detection of these cases. So we're not even able to get hold of these cases at the level of diagnosis itself. Coming to the next problem, which adds on in such a condition is the development of inhibitors. So what exactly are inhibitors? Inhibitors are basically they're alloantibodies, which actually develop in the bodies of these hemophiliacs once they keep on going with the factor replacement therapy. So this is what is adding to the already existing burden for this population. And the prevalence of inhibitors in developing countries as of now ranges anywhere between 7 to 19%. And they basically invite an exorbitant cost for management after these inhibitors get developed in the bodies of these hemophiliacs. And the costs of persons with inhibitors are more than 3 times greater than the cost incurred with those without the inhibitors. So the burden gets added. This is a lot of information, but I'll just pick up only the main points from this. The National Hemophilia Association, basically, it reported somewhere that the average annual cost of clotting factor therapies for a person with severe hemophilia is roughly $3 lakh. $3 lakh. And a person with an inhibitor usually has expenses over $1 million a year just to manage himself. In India, the therapy can vary anywhere between 1,95,000 lakhs to 5,52 lakhs per patient, according to the level of the severity of the disorder. And there are other studies also which are comparing the out-of-pocket expenses of this particular factor treatment and the average monthly income that an average family might have. And it's really disheartening to see how this problem in itself is such a huge economic burden for such patients. Coupled with that, for those which are born with hemophilia, the chances of living a life of normal duration and quality are usually reduced by 64% in upper middle countries, 77% in middle income, and up to 93% in low middle income countries. These are also kind of, statistics that are available with us. So when we look at this entire picture, we understand that hemophilia in itself is a multifaceted problem, right? Because one, at the level of inadequate screening and testing, there is a problem with the detection, first and foremost. Then there is poor access to treatment. We don't really have, enough treatment centers which are really accessible to these patients where they can come and take the preventive factors, or they can take even the, on-demand factors. There is an economic crisis which is associated with this condition. Of course, there is a functional disability because of the condition, the disease itself, the development of inhibitors, which I just explained. Then there are transfusion, transmitted infection. All of this, of course, is contributing to a poor quality of life, which definitely has an impact on the schooling and employment, but of course, is definitely a cause of emotional stress to families. So having said that, the interesting thing is that recently, the role of CAM, that is complementary and alternative medicine, has been explored and has been realized in this condition. And there has been a couple of publications previously from some case series and reports and other things, where homeopathic treatment has been given for such cases of hemophilia for over a long time. And this is where we thought that, let us explore the role of homeopathic treatment in the persons with hemophilia. and understand, how far they're able to control their bleeding or pain or other factors. And that is when we planned an open label RCT to explore the effect of an adjuvant homeopathic therapy on bleeding rate and other parameters of joint health using the systematic scales in a systematic manner. So primarily what we wanted to see was that we wanted to compare the effect of adjuvant homeopathic treatment given with standard medical management with standard medical management alone. So it was a comparative study, a 2-arm-1, in which one arm was continued on the standard medical management, and then the other one we added homeopathy. And then secondarily, we also assessed the joint health of these hemophiliacs, the requirement of the clotting factor concentrates, and also the development of inhibitors. So like I already explained, this was a prospective open-label randomized double-arm study, which was taken up at the CCRH collaborative unit at the Motiwala Homeopathic Medical College, Nasik, because they have been having, previous experience in dealing with such hemophiliacs for a long time now. At a short sample, a small sample of 53 patients, this study was completed, and we enrolled 10 to 45-year-old diagnosed cases of hemophilia A or B, who are under standard medical management and who are willing to be a part of the study, and wherein we excluded those which already had the presence of inhibitors or had a history of a very strong life-threatening bleed, had a history of active hepatitis or positive hepatitis serology, HIV, and a hemoglobin level less than 8%. So the consort diagram over here on the screen basically shows in a nutshell, how we went ahead with this study. So we assessed, just to enroll such a small sample, you will say, we had to assess almost 201 patients of hemophilia, and they were randomized, 65 of them were enrolled. And then they were randomized to either of the groups, that is the standard medical management or the standard medical management with homeopathy group. And they were followed up regularly for a period of 2 years. And every second month also, there used to be a telephonic or a physical assessment follow-up for them, which used to be taken up by the hematologist, as well as the physiotherapist, who used to do a blinded assessment in these cases for both the groups. And the results that I'm going to present here are going to be from the 48 patients who completed the follow-up of the study. So these were the two groups, which I've already explained. The standard medical management group, where we continued the factor concentrates, the FIBA, the anti-fibrinolytic agents, the anti-inflammatories and analgesics, and the homeopathy group, where in addition to all this, we added homeopathy. Both the groups were getting regular physiotherapy by the physiotherapist as far as the price therapy is concerned. So this is a specific one which is given to persons with hemophilia, where they are given a postural splint, they're advised for rest, ice, compression, elevation in cases of muscle and joint bleeds. So what we compared primarily and saw as an outcome measure was the annualized bleeding rate. So we wanted to see, how annually the bleeding rate is differing from the previous years. So we covered these patients and we observed them for a span of 2 years, and we compared annually at each year the annualized bleeding rate of all the bleeds together, and then specifically also the joint bleeds. Secondarily, we compared the joint health I mentioned, and we took this specific very important score that we use for hemophilia, that is the hemophilia joint health score, to assess their functionality as to how they're able to manage themselves functionally. We did the functional independence score, and then we compared the requirement for the clotting factor concentrates and also the number of persons with hemophilia who developed inhibitors by the end of 2 years. So at baseline, we took into account all possible factors which could have a confounding effect on the number of bleeds that these patients will have over the years. So we considered, besides all the demography, we considered what was the age at the first bleeding episode, the age at beginning the factor infusion, the type, the severity, the education, all the other demographic factors, the monthly family income, the previous year's annual bleeding rate, and also the scores of the previous year. So we wanted to understand, how these groups are basically comparable with each other at the baseline itself in terms of all these factors which can actually act as confounders to the future 2 years that we are going to observe them. And we found that at baseline, the groups were comparable. So what we had at the end of 2 years was, over here on the screen, we have shown the changes from baseline to first year in the annual bleeding rate and changes from baseline to second year in the annual bleeding rate in both the groups. And we found that the reduction in the overall annual bleeds was only 28% in the standard medical management group in comparison to a reduction of 60% in the homeopathic adjuvant group. This was at the end of 1 year. And by the end of 2 years, also the situation was quite similar. It was only 18.5% difference in the annual bleeding rate in the SMM group and a 62% change that we saw in the adjuvant homeopathy group. When we compared for the joint bleeds, we were surprised to have a very similar and a very encouraging picture even in joint bleeds, which are actually very, very difficult for these patients to manage because they definitely go in with, accompanied with a lot of pain and a lot of deformities and eventual arthropathy also. And over here as well, at the end of second year, you can see that there was a 66.72% decrease in comparison with only a 36% decrease in the standard management group. When we compared the joint health in terms of the score that was used for the hemophiliacs, then we found that the mean of the change at the end of the second year in the score, the change in the score, was significant in favor of the homeopathic group. That is the hemophilia joint health score, which means that these patients were definitely having a much better joint health in comparison with the other group. And when we compared the functionality of these groups, between these groups, we found that functionally they were better, but the results were not significant in favor of the homeopathic group. So they were doing better. We could see a greater change in the homeopathic group, but it was not statistically significant. A very alarming thing was that the reduction or the requirement of the factor concentrates in our group. Our group did not require the factor concentrate as much as that was required in the standard medical management. And once again, the requirement was statistically significant in favor of the homeopathic group. The frequently prescribed constitutional remedies were all those which are given on the screen, ranging from calcarea carb, natriumur, sulfur, lacasis, strontium carb, silicea, pulsatilla, rustox, phosphorus, calcarea fox, and thuja. The other parameter that we measured was also the development of inhibitors, and we found that only 1% developed inhibitors in the homeopathic group in comparison to two which were seen in the other group. So while the sample may seem very less, but to have such a population together and to follow them up for a 2-year span was in itself a very challenging one. And over here I presented the results from a per protocol analysis. If we do an ITT, probably the results are even more better. And standard care was the other arm that we had at hand that we compared it with. And considering all the ethical aspects, we have not been able to assess the effect of placebo. So for ethical considerations, we are only comparing with the well-known treatment which is already there for these patients. And this later part of the follow-up, they also coincided with the COVID-19 lockdown period, and hence we could not take a more frequent follow-up assessments as well as the physical health was concerned for these patients. So that is something which could have added even more rigor had we had a frequent follow-up for the joint health score. So in a nutshell, what I would like to conclude here is that the adjuvant homeopathic treatment, it can aid in reduction of the annualized bleeding rate of persons with hemophilia by thereby reducing the requirement of constant factor concentrates, reducing the socioeconomic dependence, crippling arthropathy, helping to preserve the functional ability, reducing the risk of development of inhibitors, reducing a risk of even transfusion-transmitted infections like hepatitis. And probably in the future course, what really needs to be planned and what we're also into already is a double-blind, RCT on these patients. And if it is possible to add somewhere for at least a shorter duration of placebo control and see, how we are able to compare with that. And also conduct a study on inhibitor-positive patients. But of course take up, other preclinical studies to understand the the underlying mechanism of the action of these medicines, because these were surprising changes, that we have found in this aspect. And these are just glimpses from the study where the study team at the site is taking measurements of the joint health. You can see on the right side, the joint health being measured as a part of the SCORE system, the physiotherapist who's assessing these patients, the blood drawing. And that is on the screen, a series of photographs of a pharyngeal bleeding, which was getting managed by homeopathic medicine in an 11-year-old person with hemophiliac. So that is the entire team on the screen, and a big thank you once again to all of them for their efforts in concluding this study. And thank you to the audience for this patientful listening. Thank you very much.
Thank you, ma'am, for showcasing your research aptitude through this paper. I'm certain many of us resonate with your spirit of scientific exploration in homeopathy. May I now request Dr. Abraham Jakaris, proprietor of St. George Homeopathic Pharmacy, Mangaluru, to give a token of gratitude to Dr. Anupriya Chaudhary. Thank you, sir. Thank you, ma'am. May I now request our chairperson to introduce our next speaker, Dr. Munir Ahmed R.
My mentor, a true revolutionary in the field of education methodology, is our next speaker, Dr. Munir Ahmed R., Director, Academic and Administrative Training Institute, Rajiv Gandhi University of Health Sciences, Karnataka. Dr. Munir sir is a visionary academic leader, researcher, and educator who has played a transformative role in shaping health profession educations in India, particularly within the field of homeopathy. With over 3 decades of teaching and academic administration experience, he currently serves as Director of the RGHS Academic and Administrative Training Institute, Mangaluru. His interdisciplinary expertise spans medical pedagogy, curriculum design, leadership, and academic governance. He has trained over 25,000 educators nationwide, authorized multiple handbooks of educational and research methodology, student assessment, and competency-based learning, and has been a key consultant to the National Commission for Homeopathy for curriculum reforms. Today, he will be speaking on the topic Advanced Homeopathic Education through Research in Health Professional Educations, where he will highlight the integration of the educational research into curriculum design, competency-based teaching and assessment, innovations to advance homeopathic education for the 21st century. Sir, please.
Yeah, thank you. Good afternoon. At the outset, let me thank Father Muller's Homeopathic Medical College and the other co-organizers, GHF and CCRH, for this opportunity. This presentation is a little off the track for many of us. If we are thinking research, yes, but this is not research in the clinical sense. It is research in the educational domain. You all are aware of the CBDC documents which have come in the past 3-4 years for UG and PG. And you might be wondering what was the background for this. See, these documents have not come out of a magician's hat like a rabbit. There has been a lot of background work which has happened in designing these. And some of the resources which have been referred, I'm just showing here. You can see none of these from homeopathy background. And these are either from the medical or nursing background, to some extent from pharmaceutical background. So what has happened is these resources have provided the logic, the foundations for developing the competency-based education for homeopathic context. The principles of competency-based education are neutral, are common to all, but we need to adapt them in the context of homeopathy. That is what we have done. And in doing so, the process that has happened is something to do with research. So this session is advancing homeopathic education through research in health professionals education. You can see the people wondering about the book. We have come to that stage. Okay. By the end of this session, you will be able to describe the scope of health professionals education research, illustrate the unique context of homeopathic medical education, design a model for research in HPR, homeopathic health professional education, review a sample of studies related to the health professional education, and mention the opportunities and challenges to HPR in the homeopathic context. The way I am presenting it might kind of give you a thought. What is this that I am telling you will be able to do this? In fact, in competency-based education, which we will explore a little in the further things, it is the learner who is the focus of all educational activity, not the teacher. So when I say something in my session, then my whole purpose is at the end of this session, at the end of this learning, what the participants or the students will be able to do. That is empowering the students, which is the focus and which is the purpose in competency-based education. I'll come back to this slide to revisit, to ask, are you able to do this by the end of this session? To define health professional education, just like any research, you can define it as a systematic investigation. And this investigates the different components of curriculum, like setting the objective, instructional activities, the assessment practices, faculty development, educational policies, a range of activities relevant to education in the context of health professions, and here in the context of homeopathic education, with the purpose of improving the quality and effectiveness of educational initiatives for the healthcare providers across the healthcare disciplines. This is what is a basic definition of health professionals education research, and with this we'll anchor the entire presentation. Now, what is the dimension which is happening here? The traditional models of health education have been found to be ineffective or not appropriate for the requirements of the current and future healthcare systems, because there is an increasing complexity of diseases, demographies, populations, the kind of causations, increasing complexity is there. Then the technological advancements, both in the diagnostic, therapeutic, and prognostic areas, are developing much faster. And you have a focus and a compulsion for patient-centered healthcare needs. The complexity of healthcare system is that we have learned where the doctor was the source, or the healthcare provider was the source and fount of everything. Now we have come to a situation where democratic situation where even the patient is aware of a lot of information, and in this we have to navigate as being a healthcare professional. So the health professionals education research, it enables the systematic evaluation of the current healthcare practices, and when the gaps are found, what are the innovations that can map the requirements of the future healthcare needs in the form of curriculum design, teaching strategies, assessment tools, faculty development, etc. so that it ensures that healthcare professionals are well prepared for the emerging healthcare challenges. The global shift is happening in competency-based education. We have a model of a traditional teacher whom I compare to a mobile tower who transmits the information which comes from the whatever is knowledge. Like a mobile tower transmits the signals from one mobile to the other mobile, and it just spreads the signals. A mobile tower doesn't check whether the handsets are working, whether handsets are compatible, whether the handsets are on, off, nothing. I have to send a signal, I'm sending the signal. Same way with the teacher who is in the traditional model, giving the information, transmitting the information all across, not bothering to check whether the students are learning or not learning, to a situation which is called as transformative learning, where there is a policy and there is a system of designing the curriculum with the intent of matching the future healthcare needs that are designed, that are evolved through reviews and policies into program objectives which are validated, and then it is implemented for the competency-based education, so that there is a system of lifelong learning. So this is what the trajectory of health professional education research purpose is. This is how the global shift is happening. In this, we need to understand what is the uniqueness of homeopathic education system. We can have three dimensions of homeopathic education. One is, what is the nature and being of health, nature of being and health of homeopathy. That is to say, how do you define homeopathy? How do you understand homeopathy? How do you characterize homeopathy? This is called as ontological dimension. For those who are not hardcore philosophy teachers, let me explain what is this ontology. Just imagine you have come to Mangalore. Now, Mangalore is a coastal city. And every coastal city has its own nature, its geography, its culture, its food habits, and the entire environment of a coastal city is something which is unique. Whatever you see in Mangalore, similar one you will see also in maybe Kannur, you will see in Calicut, you will see in Cochin, or you may see in Mumbai or Surat, all Western Ghat. Right? So this is what is ontology. The ontology of homeopathy is that it is characterized by vitalism. It is vitalistic philosophy, and it is something which has the understanding of person as the core, not the disease as the core. The essential feature is the person. So any research that pertains to homeopathy must focus on the nature of homeopathy. If we diverge from that nature, whatever we are doing is not according to the homeopathic principles. So this is the first baseline we need to understand. The homeopathic research, not only in the clinical or whatever aspects, but also in the educational aspect, has to align with the ontology of homeopathy. The second is the epistemology, or the nature and sources of knowledge. This is what is called as epistemological dimension. In the epistemology, how do we develop knowledge in homeopathy? Now, there are various ways of developing knowledge. In the general sense, in the ordinary sense, orthodox, you have the stimulus and the response, that knowledge is generated. You have the functional understanding of the body. All these things are there. But coming to the homeopathic understanding, the knowledge generation is something which is experiential. Now, when we say experiential, in the scientific language, you may call it bias, you may call it subjective, and not give importance. See, this is where you need to understand that homeopathy as a culture, homeopathy as a system, its ontology defies the restrictions that are put by the mainstream research models. You need to understand homeopathy has its own nature. That is the reason why because of these reasons, because the way we generate knowledge, the way you say that drugs are proved are healthy human beings. Okay, you can have the dimensions of drugs coming from toxicological provings, from the biochemical areas, all those things. But ultimately, what defines homeopathy is that healthy human being. So this is what is the epistemology. And the third is the process and learning formation. How do we process that learning? This is the pedagogical dimension. And thankfully, the competency-based education has ironed out the differences which were there in the mainstream medical education to bring it with the kind of understanding and philosophy that is there in homeopathy as holistic, as capacity building the learner. So the pedagogical dimension is the competency-based education, though which is a recent phenomenon. The very nature of homeopathy makes it something which is very, very appropriate in a homeopathic context. So these are the backgrounds with which the health professional education, the purpose it serves to build evidence-based educational practices. It enhances clinical reasoning and fosters reflective learning, the purpose of health professional education research. It creates professional identity. This is what is most important. As you conduct researches in the homeopathic context, the one thing that it has to do is to establish the identity of a homeopathic professional as a professional. And in this, perhaps, I'm being a little more provocative here to say, when we lament that the homeopathic graduates in some areas do not practice homeopathy, the reason is they have not been able to find their identity as a homeopath. That is the lacuna. So this is one outcome that may happen. Then to identify what are the effective academic strategies and develop lifelong learning habits. So this is the purpose. Now coming to the frame of conducting research, it goes with the same flow of identifying a research question here in the educational setting. Then you identify the methodology and tools. Here you will have questionnaires, observation, checklist, rubric, and sampling and the context building for the conduct of study. Then you will have the data collection, analysis, and interpretation. And finally, you have the results, which map to the question that was there. So this, the same process is there. Now for this, if we have to delineate what are the studies which would be appropriate, for the descriptive studies, you can have surveys and teaching methods. For analytical or comparative studies, you can have a kind of comparing problem-based learning with lecture-based outcomes. Or you could have experimental studies for educational interventions. In fact, comparing PBL and lecture-based could be an experimental study. Then you can have a qualitative research with focus group with the students and faculty. This is the background of how some of the elements of research methodology or research literacy are applicable in the health professional education also. Now coming to some examples of some of the studies that are conducted, there are three pillars of education. One is what are the outcomes, second is the instructional activities, third is the student assessment methods. I'll try to give an example of each of these that was conducted as a sample. How much time do I have? How much time do I have? 10 minutes, okay. Now coming to the setting of the purpose. We had a study related to curriculum planning. Maybe this was conducted in 2013-14 and was presented in the World Homeopathy Day in 2017 or 18. So what happened in this was we took the second year BHMS pathology as an example. It was seen that pathology was one of the area where the students were not performing well in the university examinations. So we structured the curriculum in Rajiv Gandhi Health University. And when it was implemented in the different colleges affiliated to Rajiv Gandhi University, there was continuous monitoring by the teachers. There was peer support, the students would support one another in various ways. And there was self-assessment where the students would continuously monitor their learning. So this happened as a context of curriculum designing and implementation. The outcomes of this, or the observations of this, we had some 14 colleges there. In February 2016, you can see the pass percentage. Some of the colleges was really good, and some it was not all that good. I would not say not all that good, except for maybe 1 or 2 colleges. After implementing this change, the contrast that you see is something which is remarkable. The mean score for the pre-test was, the pre-implementation was 87.37. What is more important is the range. The lower range was 68.42 and the upper was 96.78. Whereas when you come to the implementation, post-implementation, you can see the upper range is 100 and there are 4 colleges which test 100% result. So this is one area which explains how a planning and a planned implementation can bring about improvement in the learning outcomes. One. The second one is about a training methodology. The recent one where I had a comparative review of the faculty training models. This was about training in education methodology. We had one batch of 56 homeopathic teachers, that is 2 batches of 28 each in the CME. One was a pharmacy batch, pharmacy teachers, one was a repertory teachers batch, and the other was 219 nursing teachers and postgraduates from Rajiv Gandhi Health University. These homeopathic teachers were from different universities from Gujarat. And for the homeopathy, we had a 2-hour session, but that was what was allowed by that CME program in lesson planning. And for nursing, I had a 5-hour training session covering the entire, all the 3 components of curriculum. The outcomes are, the observations would be, like you have the homeopathy teachers, you have the nursing teachers here, the number of faculty, total marks that they scored in the that we had for in the pre-test, post-test, and the gain in the mean. Homeopathy, we had 56 and 219. The total marks for homeopathy was 10 because the components were only about learning objectives and the teaching methods. Here we had all the 3, so we had 15 marks. The pre-test mean was 0.95 out of 10. Imagine it was less than 1. These were the teachers who have been implementing the competency-based dynamic curriculum for the past 3 years. This was the level of knowledge. And in the nursing teachers, it was 6.5, almost 43%. After the training, it went up to 4.11, the score. Still, it does not touch the 50%. Whereas in the nursing teachers, it went up to 12 out of 15, almost 75%. The mean gain is not important here because it doesn't give the real picture. The real picture is that even after the training, the score of the homeopathic teachers did not touch 50%. So there is a kind of urgent need to review the way the homeopathic teachers training is being conducted, implemented, monitored, or reviewed. Now coming to the last example, this is about the academic audit. We had a subject called Advanced Teaching of Fundamentals of Homeopathy in the previous version of MD. And this was a kind of differently designed in Rajiv Gandhi Health University. So we had the post-examination, after the university examination was conducted, 3 years after the whole course, we had the students responding to certain questions. A questionnaire was there. These were the 7 domains, and these were the satisfaction mean. What is interesting here is the students were 81.6% satisfied with the examiner behavior. This is one of the gray area because examinations are not seen to be fair, but here this was something which was very important. And what was lacking was in the reflective assessment, because this is one area where we need to improve. So this is the interpretation. I can share this slide with the organizers. They can further give it to you. Now what is happening here is in the homeopathic research, in the homeopathic institutions, the research culture is not that very robust. It needs to improve. And if it can improve, you can have the critical thinking, innovations, reflective practice. The opportunities that are there and the challenges which are there, I have tabulated them. These are the opportunities which the National Commission for Homeopathy is providing. And these are the challenges that as teachers and administrators, policymakers, we need to address to. And this is one proof of the outcomes. In Rajiv Gandhi Health University, we have a separate department called RATI, RGHS Academic and Administrative Training Institute. And these are the verticals which are on-site. These are hybrid, and these are online for both teachers and also postgraduates to enable them as being competent teachers. If there are any questions, I can take them on the sidelines, not here because of the time constraint. And these were the objectives which I had projected at the beginning. I'm not sure how much of it is because you'll have to tell how much is the information that has sunk in. And this is my identity. These are the areas that I work on. And this is my contribution. Thank you.
Thank you, sir, for addressing such practical aspects of educational need for our homeopathy curriculum. We are grateful for the clarification that you gave. Now I invite Dr. Indira Fonseca from Goa to kindly present a token of gratitude to Dr. Munir Ahmed. Thank you, sir. Thank you, ma'am. Now, we again diverge into another online session with our speaker, Dr. Bhaskaran Jagdish. Settle down and engage as we connect with them virtually. I request the chairperson to give a brief introduction of Dr. Bhaskaran.
Next, online speaker, Dr. Bhaskaran Jagdish, Consultant, Anesthesia and Pain Management, Apollo Hospital, Chennai, Director, Turiya Palliative Care, Chennai. Dr. Bhaskaran Jagdish is a distinguished anesthesiologist and a pain management specialist with over 3 decades of clinical experience across India and the United Kingdom. He is the director of Turiya Palliative Care, an initiative dedicated to integrative pain and end-of-life care. A graduate of Stanley Medical College, Chennai, Dr. Jagdish pursued advanced training in the UK, earning FRCA London and DEAA qualifications. He has served multiple senior clinical and teaching roles, including consultant appointments at leading to NHS Trust in the UK and visiting professionalship in India. His research interests span integrative medicine, pain management, and palliative care, with several publications and presentations to his credit, including studies of magnetotherapy, daycare anesthesia innovations, and potentized chemotherapy in collaboration with Central Council for Research in Homeopathy. His ongoing projects explore the role of homeopathic interventions in mitigating the chemotherapy side effects and managing alcohol dependence through double-blind randomized controlled trial. Today, Dr. Jagdish will be speaking on the topic Holistic Medicine, Bridging Homeopathy and Allopathy, where he will share his unique perspective on integrating evidence-based homeopathy with conventional medicine to enhance patient outcomes, pain management, and overall well-being. So please, thank you.
Good morning. Good morning, everyone. I hope you're able to hear me. Dr. Sebastian, you're able to hear me? I'm assuming. Yeah, okay, I can go ahead. Yeah. My sincere apologies for not making it today physically. And I'm extremely grateful to Dr. Prabhu Kiran sir and Jay Sangvi, who are primarily the two people who invited me. And they're very particular. I should share some of the research work, what I'm doing in collaboration with Ayush Ministry, CCRH. So next few minutes, I'm going to talk about the allopathy perspective of homeopathy. How, as an allopathy physician, how I am successfully using homeopathy medicine in my day-to-day practice. And I am my journey towards integrated medicine. I got qualified in the year 1991 from Stanley Medical College. Then I decided to specialize in anesthesia. And I got my diploma in anesthesia from Stanley Medical College in 1993. Subsequently, there were two options in front of me. Either I can do MD anesthesia in Stanley, or I can pursue my career in UK. I decided to go to UK. I spent next 10 years in England, a fully qualified anesthesiologist and pain specialist. Anesthesia in the UK, all of us will have to choose one subspecialty, and I chose pain management as my main interest. To get a certificate in pain management, you have to compulsory. So, sound is not coming?
Yes, we can hear you, sir. Continue.
Yeah. To get a certificate in pain medicine, we have to compulsorily work in palliative care. In this palliative care experience, completely changed my life upside down. And until then, I never believed in any of the alternative medicine, and I only swear by modern medicine and what have you. Palliative care, every palliative care in the UK, all kind of alternative medicine, you name it, homeopathy, acupuncture, Reiki, and every other Alexander therapy, massage therapy, everything is done in those patients, because as the word indicates, the palliative care, those patients are unlikely to have any complete cure or resolution, whereas their suffering and symptom is very real. So anything to help them in coping with the suffering is accepted in palliative care. And in that palliative care, there was an acupuncture guy. He's not a doctor, but he's trained in China, and he'll come and do some needling to the patients. And more than a qualified doctor like me, who's finished my fellowship, I was a senior registrar, the patients in palliative care, they look forward to that acupuncture doctor rather than looking forward to me. That completely changed my view towards the alternative medicine. When I come back and shared with my consultants, they said if I am interested, I could learn acupuncture. So I learned acupuncture in the UK. When I went for acupuncture course in the UK, I was curious, but I never believed it 100%. But I picked up few skills from that course. When I come back, when I tried it on the patients, I was pleasantly surprised. Then I become a complete, I converted myself towards the holistic medicine. My uncle is a senior homeopath. He had a roaring practice in Chennai. And whenever I come to Chennai for a holiday, I used to go to his clinic, sit with him, and all the diseases which are branded as non-curable in modern medicine, like rheumatoid arthritis, hypothyroidism, he will give some medications. And I thought, and he'll always tell them it will get better, or he'll promise total cure. As an allopathy physician, initially I had tough time in understanding this, but since I was frequently making a visit to and fro from UK to to Chennai, then I was seeing the same patients coming up for follow-ups, but not only they are symptomatically better, even I find blood parameters are better. Then I asked my uncle, how is it possible? Because we don't have something similar in allopathy. He said, he encouraged me to read homeopathy, And he said, since I'm an allopathy qualified doctor, and I'll be able to grab the principles of homeopathy with ease. So this is where my journey towards homeopathy started. Then out of my own interest, once I started using some of these medications, since the results are so fantastic, I completely learned everything about homeopathy. Also, I'm a very big follower and lover of flower remedies by Edward Bach, and I use biochemical salts by Edward Schussler. What is homeopathy? I mean, from an allopathy perspective, homeopathy is a very superior nanotechnology. Let me try and explain. Modern science, we call nanotechnology, is a technology where manipulation of matter with one dimension ranges from 1 to 100 nanometers. This is a definition. What it means, let's say for practical purpose, we'll talk about ampicillin, where they take the molecule of an ampicillin, they'll try to reduce the size of this ampicillin to anywhere between 50 to 60 nanometers, because the practically available nanotechnology drugs today in the market are available from 50 nanometers. Ladies and gentlemen, when I say 50 or 60 nanometers, it doesn't make any sense. Our human hair, one hair is about 75,000 nanometers. So the nanotechnology is breaking down the, let's imagine the human hair, so with a microscopic view, and anything between 50 to 60 nanometer in diameter is coming under nanotechnology. Whereas people have looked into homeopathy medicines, the size of the molecule, and they're surprised to see anything between 10 to 15 nanometers. To do this, you need an electron microscope, and one of the homeopathy doctor successfully managed to do it in Baba Atomic Research Center, and he's published a paper. And just an atom, size of an atom is 0.1 to 0.5 nanometers. So if you club maybe 10 or 15, maybe 20 atoms, then that is the equivalent of our modern homeopathy medicine. In other words, I, as an allopathy physician, view homeopathy as a superior nanotechnology. So you can imagine our master Hahnemann, how much he was outthinking for his time, or how he can foresee things which are not perceived. Those days, even my ordinary microscope is not available, whereas he is able to bring a nanotechnology revolution in pharmacology. This is how I view as an allopathy physician. And so far, the market, whatever drugs we have in nanotechnology, they're available in chemotherapy drugs. Because as you know, the chemotherapy drugs are potentially have a lot of side effects. We'll discuss it in the next slide. And so I have done some research work in cancer. Before we go into my research, let's look into practical treatment and solutions for somebody diagnosed with a cancer. Every cancer patients, when they come and approach a doctor, they'll definitely, after the investigation, they'll be offered most probably surgery, and they may be offered chemotherapy, radiotherapy. Now the fourth and fifth, immunotherapy and hormonal therapy, are latest addition. But first three, surgery, chemotherapy, and radiotherapy, they are the gold standard treatment for any cancer patients seeking help. I am successfully using all the three treatments: surgery, chemotherapy, and radiotherapy, lots of homeopathy medicine, backed up by science. And let me evaluate one by one in the next few slides. Come back to chemotherapy. Chemotherapy is designed in killing any fast-growing cells of our body. And we all know cancer cells are the fastest growing cells. Obviously, when a patient is administered with chemotherapy, the cancer cells will die. But unfortunately, along with that, some of the healthy cells like human hair, bone marrow, gut mucosa, because they proliferate and fresh cells are made every day. So the chemotherapy agents get the signal from these healthy cells, and they go and damage this chemotherapy, go and damage the healthy cells. So patients will have hair loss, severe nausea and vomiting, bone marrow issues, etc. To minimize these side effects, anything to reduce it is a big boon to the cancer sufferers. Chemotherapy is divided into three groups of chemotherapy patients. Neoadjuvant, as the word indicates, we give this chemotherapy to a patient newly diagnosed with cancer, where the cancer cells is too big, and we cannot do primary surgery. So we give chemotherapy, shrink the size of the tumor, then we do surgery. And then second group of patients is called post-operative chemotherapy. These patients, they've contacted a surgical oncologist, had the cancer or tumor removed, and to kill the microscopic cancer deposits, we give chemotherapy. That is classified as post-operative chemotherapy. Then the last group of chemotherapy is called palliative chemotherapy. Palliative chemotherapy, as the word indicates, this is used to just give some comfort to the patients, just to reduce the size of the tumor so the patients may be able to feel better, pain relief, may be able to eat better and things like that, where we are not targeting cure. So this is the three group of patients, whereas in all the three group of patients, I have tried it, the newer form of my favorite research, the tautopathy or potentized chemotherapy. So what is tautopathy or potentized chemotherapy? Whatever agents the allopathy medical oncologist use, for example, Taxol group, paclitaxel, cisplatin, carboplatin, docetaxel, various group of cyclophosphamide, epirus, so many drugs are available as a chemotherapy agents. And the patients, they go and see the medical oncologist with all the detailed record. So the medical oncologist will give a prescription. Then they'll come in touch with me. Based on the prescription, we make tailor-made the potentized chemotherapy using the same chemotherapy agents. Let's say we'll stick to docetaxel for the rest of our lecture. So if somebody is prescribed intravenous docetaxel, I'll prepare homeopathy docetaxel by taking 1 milligram of the allopathy docetaxel, dissolve it in 100, maybe 95 ml of water and 5 ml of some preservative for the longer shelf life, like extra neutral alcohol. I unfortunately don't have access to that, so I have my own ingredients which will make it last longer. From this, I'll advise the patients to have 2.5 ml. We make it in a 100 ml container, so we ask them to have 2.5 ml twice a day oral route. How I perceive this, when we take it orally, similar to our polio vaccines. The vaccination is another controversial topic. I'm pretty sure homeopathy doctors claim it is stolen from them by the allopathy doctors. Oral polio vaccine, when we give it orally, they go and stimulate gut lymphoid tissue, but they protect the patients, the children's spinal cord and spinal nerves. Similarly, when we take this potentized chemotherapy orally, they stimulate gut lymphoid tissue, and probably some kind of immune protection in the form of antibodies forming. They go and protect all the healthy cells of our body. Whereas cancer cells, as we know, they don't have innate immunity. So all the intravenous chemotherapy, given by the medical oncologist, they'll go and kill the cancer cells because they cannot come and attack the healthy cells because they're already getting some protection from the potentized chemotherapy. This is my unique research and idea. How I got into this idea? After I come back from UK, I started my own palliative care setup because there was very few private palliative care facility, even today across India and more so in Chennai. And in that palliative care, I employed a homeopathy doctor to help me in managing the patients day to day. In spite of the best homeopathy administration of medication, allopathy medications, these patients are still going through side effects, pain, nausea, vomiting. So one day I was casually asked the homeopathy doctor, is there anything else we could do? Then the doctor explained to me there is some concept called tautopathy, but he's never tried it. Then I went and read about it. Then I got completely convinced. Then one other patient, her name is Mala. She's my star patient, and she was given only 3 months to live out of breast cancer. It metastasized, and she was in a very miserable state. She was brought into my palliative care facility, but she still wants to live, and she was going through chemotherapy. Then Mrs. Mala told me she's willing to take any risk, and she wants to try anything new. Then I explained this concept to her and discussed it with her, told her completely this is a new idea. And very first few patients, I was extremely nervous because I don't know how this potentized form of chemotherapy will behave. To my utter surprise, Mrs. Mala's general health improved like anything, and she lived for literally 9 months, almost pain-free and fantastic quality of life. She, in fact, taken some of our staff nurses outside for a celebration of her birthday. This is the few initial encouraging results I had. Then I shared it with my allopathy doctors. Then they said the only way I can either keep on improving or make this accept as a concept is by doing a research. So doing a research is another very, very challenging thing to do. So to claim you have some new technology which is helping, you need to collect data. So we rigorously collected data of about 50 patients. After collecting the data, it has to be verified and submitted to the relevant organization. I was very fortunate. I was in touch with CCRH in New Delhi. Then there was a Director General, Dr. Manchanda. He was extremely helpful and he was encouraging any kind of research. And luckily, I was in touch with him. I shared this data. Equally, outside, I was doing some how these chemotherapy drugs are helping these patients. Do they have any chemotherapy property themselves? So we decided to do it in vitro cell line study. I have few slides. I'll show you later. Also, we need to make sure this potentized chemotherapy doesn't do any harm to the patients. For that, we need to do toxicity trial. So we did this toxicity trial in AIIMS, New Delhi. Before CCRH gives approval, these are all mandatory requirements. In fact, it adds more scientific credentials and credit to my study. Then we decided, the CCRH granted me permission. I mean, we proved there is no side effects from potentized chemotherapy medicines in experimental mice. Then they gave approval. We started this before COVID. Unfortunately, due to COVID, it took very longer time. But in spite of that, we finished the pilot study in Apollo. We covered about 38 patients, including all three groups, as I was keep saying, neoadjuvant, postoperative, and palliative care group. All of them are completely doing well. And I'll show you in subsequent slides. One of the patients miraculously got rid of stage 4 cancer. This is an in vitro cell line study. I don't know how clear it is for the audience. The HUH stands for hepatocellular cancer. You can grow the cancer cells outside in vitro in a Petri dish, where once they get stimulated, these hepatic cancer cells spread like fire, or they multiply in the Petri dish. You can see the value 100 and the red line is the fast, and the timing. They can reach in very faster duration. Whereas when we put this potentized cisplatin and docetaxel in the same Petri dish, they are definitely able to reduce the dividing of the hepatic cancer cells. And we have tried it on 1C and 2C. In that experimental model, the 2C is having significant reduction. On the far right, you can see the 2C of docetaxel and cisplatin, where they reduce the hepatic cell growth by 60%. From 100, the number comes down to 41. But my 50 patients, I was experimenting with 1C docetaxel. So for practical purpose, we decided to, though we got some encouraging results, we didn't do toxicity trial for 2C. So we have we decided to stick with 1C potency. And we have done all the trial, including 1C potency. Surprisingly, we got a great, good result.
Sorry to interrupt, sir.
Another popular, sorry?
Sorry to interrupt, last 5 minutes.
Yeah, last 5 minutes, okay. So, okay, thank you. At the end of this, I will be frequently asked questions. Can this be used alone in curing cancer? And I'm afraid, unfortunately, I don't have the data, and we don't have the sophisticated full technology in identifying the right dose and the duration and frequency of administration of these medication. So we don't recommend this instead of, let's say, docetaxel or cisplatin intravenously. we have no data to say this potentized docetaxel or potentized cisplatin will cure the cancer. We cannot claim it. So we are using this to reduce the side effects of chemotherapy. Now, with the collaboration between CCRH and few other oncology centers,
Thank you, sir. Thank you, ma'am. To conclude this segment, I request the chairperson to introduce our last speaker, Dr. Suhana P. Aziz.
Last, but certainly not least, we are honored to welcome a young expert, Dr. Suhana P. Aziz. She is an accomplished homeopathic physician and clinical researcher with over 9 years of experience in evidence-based homeopathic research. She currently serves as a research officer, scientist 2 at the Central Council Research in Homeopathy, New Delhi, under the Ministry of Ayush and Government of India. Her extensive research experience includes authorship of 10 peer-reviewed research papers and contributions to 4 reference books on homeopathic research and methodology. Trained in good clinical practice, new drugs and clinical trials rules, as well as biomedical research ethics under the Indian Council of Medical Research. Dr. Suhana also holds certification in biostatistics and in geographic information systems in public health from the Public Health Foundation of India, New Delhi. Today, she will be presenting on the topic Immunomodulatory Effects and Safety of Arsenic Album 30C in Healthy Participants, a double-blind, randomized control trial, providing scientific insights into the potential as an immunomodulatory agent in preventive healthcare. Madam, please.
Yes, thank you, ma'am, for the kind introduction. So I take this opportunity to thank the organizers of EXPLORA 2025 and the Father Muller's College for the kind invitation here. I can see very little crowd, but then I thought I'll get done with my presentation. It is already stretched. So a good afternoon to all of you. This particular presentation, I'm just taking you back to the COVID times. So you all have heard of the medicine Arsenicum album 30C. It was widely used as a prophylactic for COVID-19. For a long time till the vaccination was there. As you all know, the COVID-19 epidemic started in January 2020, and the vaccination in India was rolled out in January 2021. So the time in between, the 1 year in between, like Arsenicum album 30C was widely used by the population of India. So this is one study which CCRH has conducted to understand the immunomodulatory effects of Arsenicum album 30C and also to establish the safety of the drug. This was a double-blind randomized control trial. Just a brief introduction about COVID-19. As you all know, it was a major public health concern of exponential level. In India itself, around 4.5 crore population was affected and 5.3 lakh deaths were reported. So as you all know, the Ministry of Ayush issued the advisory for coronavirus. So in that, Arsenicum album 30C was announced as a prophylactic medicine for COVID-19. And CCRH, through its network of colleges and institutes, distributed AA30C to around 10.6 million population of India, and out of which 5.8 lakhs were analyzed. Dr. Anupriya and her team had done that to conclude that the consumption of prophylactic significantly reduced the risk of contracting COVID-19 in high-risk groups.
So these are some of the evidences which we had before we started with the to understand the immunomodulatory effect. So prospective parallel cluster cohort study was conducted by CCRH and suggested that AA30C had a protective effect of about 74.4%. Then in a few treatment studies of COVID-19 also, arsenic amalgam was one of the important medicines that had come up. So CCRH also conducted certain animal studies at its Noida Institute and Kolkata Institute to establish the safety of AA30C in animal models. So despite the population-based studies, no clinical trial was conducted to understand the immunological response of AA30C in humans. As you all know, AA30C was popularly called as an immune booster, but nobody ever knew what immunity or what fraction of immunity was being modulated. So that's how we started with this particular trial. So in Jan 2023, we conducted this phase 2, phase 3 double-blind randomized placebo-controlled clinical trial to assess the efficacy and safety of AA30C as a prophylactic medicine. So the study was conducted at the Pathanamthitta district of Kerala. So 10 study sites were selected from the government, actually the 10 government homeopathic dispensaries were selected from the Pathanamthitta district. This study was conducted in collaboration with the Department of Homeopathy, Government of Kerala. And the CCRH Institute, NHRIMH Kottayam, the National Homeopathy Research Institute in Mental Health, was the facilitating institute for this particular study. So the study objective was primarily to elucidate the immunogenic response of AA30C in COVID-19 prophylaxis, even though in Jan 2023, the COVID had already waned out, but still we started with the study proceedings in 2021, and finally we got all regulatory approvals by 2023 only. So here we were trying to see, did ARSALB, cause any changes in CD3, CD4, CD8, IF and gamma, T cell, B cells, the dendritic cells, the natural killer cells, any kind of immune response did ARSALB make. Then we also, one of the primary objective was to estimate the innate and acquired immune responses and the natural killer cell response by RT-PCR array analysis. Then, of course, the secondary objectives, we added the toxicological evaluation because at that time the controversy was raging that ARSALB is a poison, it is creating, liver toxicity and all that. So many adverse propaganda and campaigns were going on at that time. So this was one of the important secondary objectives that we had added. Then also we tried to see the number of participants who developed COVID-19-like symptoms. Then to identify the participants, if anybody tested positive for COVID-19, then COVID-19 antibody responses between vaccinated and unvaccinated participants. So in the Pathanamthitta district, the study site, almost 96% of the population was vaccinated by the time we started the study. So this is a study overview. So this is the Pathanamthitta district. We had 10 study sites. So we had our screening process, RT-PCR screening was there, then we did screening for liver and renal abnormalities, then only we enrolled the participants. So we had 3 schedules of the study, each of 21-day duration. Then the study, like the 21-day duration was as per the Ministry of Ayush advisory itself, like ARSALB was given continuously for 3 days, and then for the it was asked to be repeated every 21 days. So that same thing that we followed. So we had 3 schedules of 21 days each, and each participant underwent 7 blood draw visits. Okay, so we had, this was a 66-day trial. So we drew the blood of the participant for like 7 days. For each schedule, before we gave the medicine, we drew the blood. Then 3 days we gave the medicine, and after, on the 4th day, again we drew the blood. So like that, we did it for the 3 months. And at the end, that is a visit 17 was the last visit. So during that visit also, we drew the blood to understand the changes. So the samples, with the drawn sample, we conducted the liver function test, the renal function test, the blood count, the peripheral smears, the immunological assays, all these were conducted in the samples drawn on the respective study days. So these are the study outcomes. So the trial was implicated, how we selected the 10 study sites. There was a short survey that we conducted to identify the 10 study sites, and the study was rolled out in Jan 2023. So we had a couple of MOUs, as I said, with the Department of Homeopathy Kerala and with the Translational Health Science and Technology Institute under Department of Biotechnology, Faridabad, India, where we evaluated the immunological responses. They have one of the biggest FACS facility, flow cytometry facilities of India, available in India. So we got all the regulatory approvals. It was registered in the CCRH. We also had a data safety and monitoring board, DSMB, which monitored the study for any safety-related issues that arose at each of the schedule. So these are the photographs of the MOU exchange. So this is how we implemented the trial. So this was a very logistically challenging study. So in Kerala, the laboratory we engaged for drawing the blood samples, because there were 10 study sites and simultaneously we had to draw the blood samples on the designated days and on the designated visits. So we had a team from DDRC SRL laboratory, which was an ICMR approved and NABL accredited laboratory. So they had, fortunately, they had their collection centers at all the panchayats of this Pathanamthitta district. So that was fortunate for us. So their team was always ready there. And from Pathanamthitta, the samples had to be collected and quickly transported to the Kottayam main facility where the peripheral blood mononuclear cells were isolated, the serum samples, plasma samples were processed. So that was logistically challenging, and it took us a lot of effort to coordinate, and fortunately we were able to complete it successfully. And then the collected PBMC samples were stored in our central freezer facility. We had to store the PBMCs in -80-degree freezer. At a later time only, we transported this PBMC samples to the THSTA Faridabad to do the immunological assays. So the samples were almost stored in the freezer for about 3 months. Later on only we transported it in liquid nitrogen transporters. So this is the study implementation. So all the site PIs at the different government dispensaries were the medical officers of the government of Kerala. So they were quite instrumental in enrolling the participants who came to them and in adherence for the 7 blood draws that they had to take. So these are the PBMC isolation training and all we had to give to the laboratory. Like people from THSTI, the scientists from THSTI came, they trained the personnel at the lab as well as our staff. So these are all study rollout photographs, blood draws, study monitoring, sample processing and storage. So the overall status of the participant enrollment, we screened 256 participants. We enrolled 212 participants. Around 44 were excluded for various reasons, like some were having, abnormal liver and renal abnormalities. Then participants dropped out were 19. Participants who completed study, finally who completed the study were 193. This was a double-arm study. We had a placebo arm as well as the intervention arm. This is a consort diagram. I'm not going into the details. So the laboratory parameters, you can see the liver function test, renal function test, and the CBC was done. So these are the baseline characteristics. We had non-comparable values for like ESR, serum creatinine, and uric acid at the baseline. There itself it was significant. Then the safety data analysis we did, a statistically significant difference between the groups, between the placebo and the arsenicum we found in the following hematological parameters: the eosinophils, the neutrophil lymphocyte ratio, erythrocyte sedimentation rate, and serum creatinine. The serum creatinine levels were slightly increased in the placebo group, not in the ARSALB group. Then the Data Safety and Monitoring Board was chaired by a senior biostatistician of JIPMER, Pondicherry. So they recommended that no serious adverse effects due to the drug arsenicum album have been reported from this RCT of 66 days duration. So they gave us a short-term safety certificate for the study. Key results of the safety analysis shows that AA30C modulate hematological parameters. It did not induce liver injury and did not induce any renal injury. Here you can see the statistical significance between the groups for eosinophils, NLR, ESR. Then hepatological parameters were all non-significant. No changes in ALT, AST or alkaline phosphatase, none of the values. So RSAL30C is quite a safe drug. Renal parameters, as I said, there was a change in the serum creatinine in the placebo group. It was higher than before they started with the placebo. So the analysis of immunological responses were done in 1,351 samples of the different visits. It was conducted at the Immunology Core Lab and Immunobiology Lab facility of THSTI under DBT Faridabad. So this was a flow cytometry analysis plan. From the cryopreserved PBMCs, we try the immunophenotyping and the intracellular cytokine staining was done to understand, T cell, B cell, NK cell as per our objectives. So finally, the key result of the immunological assays says that arsenic amalgam 30CH modulates host innate immune responses. A notable reduction in the CD4 plus CD38 plus T cells in the intervention group, that is the RSALB group, suggests a favorable shift towards immune regulation. The CD4 plus interferon gamma and interleukin 17 showed a significant increase in the RSALB group. These subsets play a crucial role in mucosal immunity, antiviral defense, and immune priming. The increase in IFN gamma and IL-17 coupled with a reduction in T cell activation markers suggest a targeted immunomodulatory effect. No significant increase was observed in tumor necrosis factor or IL-2, indicating that the intervention enhanced certain immune functions without inducing any kind of systemic inflammation. So its immunological safety was also, we were able to establish to an extent. So frequencies of innate and adaptive immune cells. In the innate cells, the monocyte, dendritic cell, NK, NKT, no significant differences were observed in the cellular subset among the control and intervention groups. There was no difference in the number of the CD4 and CD8 cells per se, but only the activation markers were elevated. So this I have already mentioned, there was no significant increase in inflammatory cytokines also. So with that clinical trial, we got some significant insights into the antiviral effects of RSAL30C as well as immunological response. Now, one of the primary objectives, we wanted to do the gene expression studies that it's currently ongoing with at the Manipal Institute of Virology. We had exchanged an MOU in July 2024. The analysis of this, why this activation has happened. So we are looking into the 84 gene panel at the Manipal Institute of Virology, and we have got some positive leads on it. Our work is ongoing, and probably we'll get the final results by January next year. So we are hopeful of getting that. So this is, the study protocol was published in a PubMed Index journal long back, and the study results have been communicated to a peer-reviewed journal now. It is under consideration for review. So this is our study team led by DG CCRH. This is a study team at CCRH headquarters and NHRIMH. This is a study team led by Dr. Biju Kumar he was a district medical officer of the Pathanamthitta district. He and his team of doctors were quite instrumental in the success of this study. So that is the conclusion. Thank you so much for your patient listening.
Thank you, ma'am, for your evidence-based scientific exploration of homeopathic remedy during pandemic. Now I invite Dr. N. Balaji, former Director of Ayush, Government of Pondicherry, to present a token of gratitude to Dr. Suhana P. Aziz.
Well done. No? Thank you.
Thank you, sir. Thank you, ma'am. May I now invite Dr. Girish Navada, the MS and Professor HOD of Homeopathic Psychiatry of Father Muller's Homeopathic Medical College to present the tokens of appreciation to our moderator and chairpersons for their valuable contribution to this session. Thank you, doctors. Now, I would like to invite our moderator, Dr. Dheeraj Samuel, to share his concluding remarks and bring this session to an end. Welcome, sir.
I really don't know whether I'll be doing justice if I don't mention every speaker and what they spoke about, but then the crowd is not there. But then I will be doing injustice to the speakers who did it, so I'm going to take some time off to say quickly what they said and to wrap up what they did for the justice that I need to do for the session. I'm so happy that I've been given this privilege to witness and moderate these sessions by some of these great researchers, starting with the abstract from Dr. Ashley Ross. It's not very easy to validate and prove some of these medicines that have already been proved. And we wonderfully saw the reproving of botulinum that he mentioned about. And together with his reproving and upholding this principle of evidence-based prescribing, I think homeopathy is going to go to another level of understanding and scientific perspective. The research strengthens evidence-based homeopathic practice and enhances the individualized treatment strategies, I'm sure. So I'm very happy to hear from the amount of time that they've taken for their research, but these were presented to us on a platter, very short and sweet, but then I'm sure that this has advanced our mindset in terms of looking at it with a scientific mindset. Dr. Vinny Krishnan, again, a pioneer in integrative oncology. The molecular profiling of homeopathy, the topic that he mentioned today, and he shared his research exploring the mechanistic studies showing homeopathic medicines, arsenic iodine, and the interaction at the molecular level, the influence of the tumor microenvironment. This work bridges the traditional principles and cutting-edge science, offering promising directions for integrative cancer research and care, which again was so enlightening. Dr. Anupriya, again, the randomized controlled trials and the validation of the scientific credibility of homeopathy with those definitely the addresses the methodological challenges. They strengthen the confidence among healthcare professionals and promote a wider acceptance of homeopathy in the global health system with such research. And we have a way to go with such people in the helm of affairs. I think we have a bright future for homeopathy. Dr. Munir Ahmed again, a lot was said in a very short time. I had the privilege of being under him as a student when I was doing my post-graduation, but then that is where it started about a very standardized way of bringing in curriculum and advancement in education in homeopathy. And he talked about the insight on the necessity of including the ontological dimension, the epistemological dimension, and the integrated educational research that is necessary for bringing in the quality and the credibility of us being globally accepted as a homeopathic branch. So again, it was very insightful. And we had the online sessions where we had Dr. Bhaskar Jagdishan speak to us from a researcher from the Apollo, a medical doctor, an anesthesiologist, talking in favor of homeopathy and bridging the gap between homeopathy and allopathy, emphasized the integrated evidence-based homeopathic with conventional medicine, which improves the outcome of and the strategy that we can use to bring in the outcome and the improving the life of people suffering from cancer, and of course the overall well-being through our collaborative holistic care model was emphasized there. Again, we had Dr. Jay Shangvi, who presented on magic and miracle of minimum dose. As he very clearly said, keep it simple. And of course, the talk focused on bridging public understanding between science and compassion, emphasizing how integrative approaches can foster trust and improve patient care. With single doses, we saw the wonderful results that he mentioned, and it was really insightful and wonderful, sir. Thank you. And of course, a big study that we had, and the final thing that we mentioned about Dr. Suhana, the evidence from the controlled trials that was in assessing the effects of Arcticum album 30 as a potential immunomodulator agent, and the key findings of the safety profile and the implications that we saw just in a presentation was again so detailed and insightful. And I thank all of you for having patiently listened to these sessions. The idea of all this is to understand the necessity of having a research mindset, basically. There's a lot that we need to present to the world around us that we are no far behind. As many of these doctors presented, that we have to integrate and also present ourselves better in the scientific world. Thank you once again for giving this opportunity to moderate this session. Thank you one and all.
Thank you, sir, for your inspiring words of encouragement. Now, I would like to invite our chairperson, Dr. Manjula, to say a few words. Welcome, ma'am. Yes. I wish to express my sincere gratitude to the organizing committee, EXPLORA 2025, for honoring me as a chairperson for the scientific session. It was a privilege not to be a part of such a well-organized and enriching event. I also extend my sincere thanks to the chairman, EXPLORA 2025, Dr. Prabhu Kiran, the man behind the wheels, whose leadership and vision have steered this event to success, and all the faculty and students whose efforts made this dream come true. Thank you one and all. Thank you, ma'am, for your kind words. Before proceeding to lunch now, I would like to take this moment to thank our sponsors for their support: Durga Agency, Green Tech Enviro Solutions, Ideal Chicken, Joy Furniture, Lighting Paradise, Lifeline Surgicals, Melina Electricals.